morning, everybody. It is Tuesday, September 28th, so welcome back. Happy to have everybody and really excited for the programs that we're going to share with you today. I know we're starting off with the part 2 from yesterday's part 1 on tips and tricks. So I think that's going to be a really great follow-up to the information that Adam and Julia provided yesterday. Before we get into that, as always, use the Q&A. It's been really fantastic. I think for the most part, we've been able to address questions during the sessions. If there are things that you didn't get answered, we're going to try to follow up, especially during that office hours session that we've been mentioning this Friday. That's at 9 a.m. That's open to anybody. And so if you have a burning question, please do use that time to follow up. As always, we're also making sure to put both the slides for each day's sessions on the conference webpage. They are available there. And also any other materials that are referenced or shared, we'll either post them as part of the conference webpage or share them back out as part of follow-up emails when we share out links and the evaluation. So do take a look also for that evaluation for this week's sessions. They will be shared with you either Wednesday afternoon or Thursday. And we're actually going to do something a little different this morning. I know that we've had poll questions throughout every session throughout the conference. We're actually going to do a couple of poll questions this morning. I think these are questions that we haven't yet asked, and I'm not sure that we'll get a chance to ask in some of the other sessions that we have. And really, we wanted to try to get a better sense of just where everybody is in terms of what they're currently doing and going to be doing for open enrollment. So this first one is, do you plan to conduct any in-person outreach or events for open enrollment? Really trying to get a sense of, are you in person at all? Are you all in person? Have you been in person maybe this whole time? I mean, this question doesn't specify that, but it'll give us a sense of where you are right now. And so it's yes, all will be in person. Yes, some. No, not yet, and not sure. And then you'll see there's a second question below that. You might need to scroll down to be able to answer that one. And it's similar, but this one's about appointments. Do you plan to conduct any in-person appointments during open enrollment? And same answers, yes, most or all, yes, if requested or needed, no, not yet, or not sure. So we'll give you a few more minutes not a few more minutes, a little bit longer, seconds to finish those. And I think we're about done. Thank you, Mike. So, okay, so no, not yet for the most part, but it gets pretty, it's kind of a mix. Yes, some, and no, not yet. So, and then a fair amount of people not sure. And I think that's kind of how we're all feeling right now, is just a lot of not sures and waiting to see where we are even a couple weeks from now. And then looking at the appointments, similar, a little bit heavier on the yes, if requested or needed. So putting a little bit more emphasis perhaps on doing appointments in person if needed. And for those of you who have been doing this, who had started doing this before the pandemic, you know that in-person appointments was the way it was done. Doing it over the phone was really not done. And then it started being allowable right before the pandemic. And obviously that really came into handy that was even allowable, and something that some people had practiced doing when the pandemic struck. And so we all pivoted. One of the things that we have experienced and talked about with Covering Wisconsin is just Well, on the one hand, there are some benefits to doing enrollment over the phone, obviously accessibility, being able to serve anyone seriously anywhere. Obviously, there's a downside. Those phone conversations could be much more challenging, especially if you were working with those who have barriers to language and understanding. Maybe somebody is just needs to be able to see something in front of them. And obviously we can do some level of video support. But education is something that we have found to be a much more of a challenge. And so we are looking forward to being able to do more in person. But I think for the most part, as I'm seeing here, it's a mix. We're not totally all there yet, but I mean, some of you are up close to 30% are expecting to do most or all in person. All right. Well, thank you for that. That was really helpful for me to see. I know there was a lot of folks on our team who are also very interested to know kind of what's happening out among our attendees. I did also want to mention, so yesterday my Zoom cut out right at the very end. I wasn't able to share the gift card drawing for yesterday. So I'm actually I'm gonna double that up with today's. Hopefully my Zoom does not cut out again. If not, I still have the third day. We can still do them all. But rest assured, we do have one for yesterday. So we will share that. And just for your information, in case anybody was curious, Mike did post in the chat. So there is some information in the chat for everybody where you can find conference recordings and the slides. It's not on if you click on the conference page off of our website, you still need to hit the conference menu, and then that'll take you to all the information about the sessions. All right. Well, I know we're a few minutes early, but you know what? It's always better to have a few minutes extra than to have fewer. So I think we can go ahead and switch it over to Adam and Dave for this morning's first session. So you all had Adam as a presenter yesterday, so you're familiar with him. So thank you again, Adam, and I will kick it over to you.
No problem. You know, I love this stuff. So Dave, are you good to start a couple minutes early?
Just need to set up one more thing, but you can go ahead and start chatting.
Okay. I will stall. No, I'm kidding. All right, we are joined this morning by Dave Chandrasekaran, who is a health policy expert and a volunteer CAC. He used to work at the Center for Center on Budget and Policy Priorities, which is pretty cool. And he's an old pro of this conference. He's been a frequent staple in teaching people how to look at plans, how to help consumers choose a plan, and really just kind of understanding the market in our state. And this is a good pickup, I think, from Julia in my session yesterday, because we talked about skills and how to have these conversations, but then this is going to be a little bit more detail oriented and technical in terms of how to assist consumers. And the question, I'm monitoring the Q&A. I will be doing that. I will answer, I'll type if I can, if it makes sense to. Otherwise, I'll indicate that we'll answer live. We'll try to get to everything. If questions are similar, I'll do my best to curate those. And I will say for that first one that the slides are going to be available after on this one, and I think that's by design. And then how do we participate in Friday's question session? That's, I'll make sure the link gets posted and sent out. I think Mike's maybe already sent it out, and Courtney's going to answer that for you. It's really just my meeting space in one of the platforms, so it won't be very difficult to get in. All right. So Dave, you got your slides ready to go?
Yep.
All right. Well, without further ado, I will kick it over to you and monitor this Q&A. Here he is.
Good morning, everybody. Very happy to join you all again. If there's any returning folks over the past few years, hopefully remember that we've been able to do these presentations together for quite a long time. And I've always mentioned to my folks that working with you all in Wisconsin's sort of one of my favorite groups to work with, just because you all are some of the more sophisticated assisters around the country. You really get a lot of this stuff, not just when it comes to eligibility, but on these issues related to plan selection that tends to be some of the more complex stuff that assisters often struggle with. And one of my favorite notions is just how much I learned from the presentations I give here with you all, and how much I really appreciate the opportunity to work with you all. I am sad that we're not in person because, as you know, I really love enjoying the magic of the Wisconsin Dells. But what I am hoping to do this year is really help us understand not just the traditional elements of how private insurance works and what we're seeing in the marketplace, but it's quite a new world, as you know, in 2021, because of how the laws have changed and how much more is being offered to people, including for folks who are higher income. So it might actually increase your workload, as we'll talk about in a second. So I'm going to go ahead and share my screen, and then we can get started. And for those of you who recall, one of the things I really appreciate doing is having an interactive experience. And so you'll be seeing some parts of it at the end. But I'm really here just to help us understand what is the most effective way to help consumers through the marketplace enrollment process. And if you are a returning veteran, I'm hoping you will get a lot out of this, even if you're familiar with the concepts. And if you're someone who's brand new, then obviously using this as sort of a baseline element. But if you are returning, some of these things are going to seem pretty easy because you've been doing this as a veteran for quite a long time. And what I'm hoping can add to is sort of some of the ways, not just what is a deductible, but how to talk about a deductible to consumers. Or not just the fact that there's like how to search for a prescription drug, but how you integrate that search in some of the more complex aspects of it. So why don't we go ahead and get started? So I'm just describing the different elements of the section of the presentation we're going to cover. We'll start out by just giving an overview of what is included in private insurance. Then we'll see what are some trends we're seeing in the marketplace and how those plans are changing and what might be coming up for next year. Then we'll try to integrate all this information into strategies for helping a consumer pick the plan that's best for them. And then we'll pause for questions after section 3 before we go into the last section, where we're going to go on to Healthcare.gov together. And through the window shopping site, we're going to look at 3 different scenarios of families looking for coverage using actual Wisconsin plans that are available for this year to see how we would help them in this process. So let's go ahead and get started with this first section, which is really walking through marketplace plans and private insurance. So as you're probably very familiar with, if you've been returning, that there's 5 main elements to a marketplace plan to any private insurance, that including those that you and I might have. And that includes the premium, which is just the monthly fee that you pay to be a member of the plan. There's all of the cost sharing, so deductibles, copays, things like that. And that's referred to as the plan design. Then there's the benefits that are covered. There's the list of prescriptions that are included and how they're covered. And then there's the network of providers you're able to see with this particular plan. So we'll get started on the cost sharing side. And again, if you're new, then this hopefully is an introduction in what is involved in a health plan. And if you're returning, I really hope this is a way that if you have a new customer who isn't familiar with private insurance, maybe someone who was on Medicaid for a long time and their income went up, you can kind of help explain some of these factors. And so as we said, there's a premium. That's just a monthly charge. I think most folks are pretty familiar with what that is. Every health plan will have a deductible, which we'll talk about in a second, as well as an out-of-pocket maximum. And when you're looking on Healthcare.gov, it's sort of laid out in this way. So you can kind of get a sense of a snapshot of each plan. Then there's the copays and coinsurance. And in this view, it'll show the 4 most commonly applicable services: primary care doctor, specialist doctor, generic drugs, and emergency room. But obviously, if you want to see more details of the plan, you click on the plan details button, and it takes you to the page that lists all of the different elements of the plan in great detail. And there's collapsible sections here. So if you want to click on the cost of medical care, for example, that's going to bring up the deductible, all the different services and how they're covered, what the copay, coinsurance are, and any kind of unique aspects of how they apply. And then another thing that's available, as you probably are familiar with, is there are certain documents that every plan will have, including the summary of benefits, which is one that's very useful, that goes into even greater detail than what's available on the website. and often is something that I strongly recommend you looking at if you're walking through how a plan works for a consumer. So I'm sure for those of you who are returning, you're very familiar with this document, the Summary of Benefits and Coverage, or the SBC. And as you can see here, it kind of lays out how the deductible works, what it applies to, and there's other elements as well, like each copay for every service that's available. So the screenshots you'll see today are going to be from both the Healthcare.gov site as well as the Summary of Benefits document. So one of the most important things I see, and if we were in person, I would ask you to raise your hand if you've ever had a consumer that had a problem understanding what a deductible was, or the out-of-pocket maximum. And you can imagine, I see Adam raising his hand, you can imagine that pretty much every assister I've ever worked with has had consumers who've dealt with that, and for good reason. It's really complicated stuff. So one thing I did in the first open enrollment, and I failed to mention that I'm also a certified application counselor in Virginia over the years. And so really learned from the frontline experience, especially those first years when Healthcare.gov was not so agreeable. And so we take we take a piece of paper and I draw visually some of this stuff so that folks can understand in greater detail how this works, because it's generally different than than insurance for your home, insurance for autos. And so I kind of say, imagine through the course of the year, there's an amount of medical expenses you're going to have. It might be a little bit, it might be a lot, we don't know. And then let's take a sample plan that has a deductible of $2,000 and an out-of-pocket maximum of $6,000. And we kind of described that when you're at the beginning of the year with a plan like this, you're going to have to pay the full amount of your medical bills. So whatever those charges are from the doctor's office, you're going to have to pay them. But if you happen to have a certain amount of medical expenses, in this plan's case, $2,000, well, you've now hit the deductible, or you can say you've met the deductible. Now, this might happen very late in the year because you didn't have a lot of medical expenses throughout the year until November. It might happen very early in the year if you have a lot of issues. You had an accident at the beginning of the year. And for many people, they don't hit the deductible at all. But once you do that, from then until the end of the calendar year, you're now splitting the cost with the insurance company. You're just paying a small amount for each care you get. It might be a copay, a flat fee, or it might be co-insurance, which is a percentage of the bill. And the insurance company is going to cover the whole rest of the bill. Now, anyone who hits the deductible, usually they sort of remain in this phase. But if someone has a really big year in terms of health needs and they end up getting quite a lot of care, then even those copays or those co-insurance will add up. And if they add up to an additional $4,000 in what you spent out of your own pocket, well, you've now hit this out-of-pocket maximum, or you've met the out-of-pocket maximum. And for then on until the end of the calendar year, you don't pay anything. The insurance company covers the whole tab of any medical bills. Again, most people don't hit this out-of-pocket maximum because they have care needs that are much lower than this value. But some people do, and it's sort of a huge protection for them if they have major health needs. And so it's something worth explaining to folks if there's someone that describes to you a lot of health needs or a planned surgery or procedure that they might go through. Now, one of the most important things I emphasize, and you'll see this throughout the presentation, is the concept of first dollar coverage. And so we just said in the last slide that there's a deductible, and you have to meet that deductible first, and then after that, you pay copays and co-insurance. And so here's an example of a plan that's actually from Green Bay, Wisconsin, from a couple years ago, that shows for some of these services that are highlighted, it's a 20% co-insurance after the deductible, or $50 copay after you hit the deductible. So that's pretty straightforward. But there's some services here where the deductible doesn't appear to apply. And so you can see here for primary care doctor, it's just a $50 copay, and you don't have to worry about the deductible. That's what you start on day one. And so they call this first dollar coverage because as soon as you pay your first dollar in premium, you're getting the insurance benefits kicking in. They're already helping you out with some of those bills. It's a pretty important thing because there's a lot of plans that might have big deductibles, especially for people who are on a budget and don't want to buy a plan that's more generous. But at least there's some access to care without having to meet that deductible that might meet most of their needs. And I want to kind of describe how you might hear about first dollar coverage because it's often explained differently across the different companies. You might hear that that service is pre-deductible. So primary care is pre-deductible, or that it's exempt from the deductible. You might say that it's not subject to the deductible. Or you might hear that the deductible doesn't apply or is waived for that service, let's say for generic drugs. You might say that the service, the copay amount is before the deductible, so $50 before the deductible. And then very common, as you just saw in this example, you just won't see the words after deductible, which suggests that that particular copay, that service doesn't have to worry about the deductible. So it is first dollar coverage. Now, one of the things I also wanted to mention, and it's something I originally had been putting in the trending section over the years, but now it's pretty much a staple, is this concept of a partial exemption to the deductible. So in this example, you can see that it says that there's, for a primary care visit, there's a $25 copay / for visits 1 through 3. After that, the deductible applies, and then after that, it's a 35% coinsurance for visits 4 and after. And so it's allowing the consumer to get some first dollar coverage. So a couple visits without having to worry about the deductible before they then have to worry about the deductible. And then after the deductible phase, then they are in the coinsurance phase. So it's sort of 3 different scenarios they'll have based on how many visits they've had. And again, for consumers who are on a budget, who want to buy a plan with a big deductible, and maybe that plan isn't so generous that it offers complete first dollar coverage, a plan like this might offer enough for most consumers who just have a handful of needs or just want to get a couple different visits in through the year because they generally are pretty healthy. I just want to show on the Healthcare.gov site how they'll often display this. So you can see here for the primary care doctor, it's $35 / 35% coinsurance. Now you'll notice it, and that's on both the summary box at the top as well as the line item when you're looking in more detail. But it doesn't mention how many visits. And so what you need to do in that case is either look at the summary of benefits and coverage, which will explain it very clearly as we just saw, or you click on this limits and exclusion link that's bottom here, and a pop-up will come up and it'll mention how many visits. And in this example from a plan in Arlington County, Virginia, where I volunteered, it shows you that there's 5 visits with that $35 copay amount before you have to worry about the deductible. I want to touch on briefly about HSA plans, and you may be familiar with those, but if you're new, you may not be understanding how they work. An HSA plan is it's a health savings account eligible plan. And to be HSA eligible, you have to have a certain deductible that's above about, I think, $2,300 or $2,500, changes from year to year. And then, but you have to hit the deductible before any services kick in, before you get any reimbursement from the insurance company. So it has no first dollar coverage. And that's important because, again, for consumers who are pretty healthy and don't worry about it, these tend to be the cheapest plans on the marketplace. But you can see the plan on the right, it has certain services that do offer first dollar coverage. So the plan on the right is not HSA eligible, which is fine. And the way a health savings account works is that you are consumers able to put in their own money into an account, an HSA account, up to a certain amount per year that's pre-tax dollars. And so it allows you to then use those pre-tax dollars in that account to pay for medical services. And the notion was it was sort of creating consumer responsibility. You're in control of that money, so you're going to be judicious in how often you use care and not use overcare, but you're getting this tax benefit. It kind of started many decades ago. I think for most of the consumers we work with, though, very few of them have enough extra money lying around to put into a HSA. And so it doesn't really offer that tax benefit, and it just sticks them in a plan with a big deductible and no first dollar coverage. So here's an example from several years ago in Georgia, where there's another plan by the same company that's almost identical in terms of a lot of what they offer, but it has some first dollar coverage, and it's only in this case $25 more expensive. So for paying a little bit more per month, they're able to get some first dollar coverage, and that might be value for some consumers who have a little bit of healthcare needs. Now, one thing I often saw early on in enrollment during the first couple of years is people not really understanding, well, what counts towards the deductible or the out-of-pocket max. And so I kind of want to bring back that diagram we used before and apply it to this plan on the left, on the right, that has the deductible of $4,700 and the out-of-pocket max there. And so you can even do this with consumers if you want to explain. You can show, well, here's certain services that you have to meet the deductible first before the insurance company kicks in. So in that case, at the beginning of the year, if you use any services, you actually have to pay whatever the provider charges. And you don't know what that is. You know, it's pretty not transparent in terms of what is charged from the healthcare system. And so I just made up some values here that a lab will involve $120 that you get charged, and maybe there's a brand name prescription drug that's $200. And when you pay those out of pocket, when you get that care, those amounts do count towards hitting that deductible, and they do count towards hitting the out of pocket maximum. But when we switch over to the services that are exempt from the deductible, that offer some first dollar coverage, you know exactly how much that'll be. So the $35 and $15 respectively. However, those payments do not count towards the deductible. So if the deductible is waived for those services, then the payments for those services don't count towards your deductible. And that's often something consumers got confused with, because they'd say, hey, I used a lot of care, and when I called, they said I haven't made any dent in that deductible. Why is that? But those payments do count towards the out-of-pocket maximum. So this is something you can do just if you have consumers who are very concerned about this or aren't understanding how this works. It's sort of a visual representation of these concepts. I want to briefly touch on the metal tiers, so the classifications of the different plans sold on the marketplace. I'm sure, again, many people are completely familiar with this. But if you're new, just as a quick summary, there's the different bronze, silver, gold, and platinum levels. In general, bronze will have much higher deductibles and also much higher copays. And then the platinum and gold plans will have much lower deductibles and copays, and often more things will be exempt from the deductible. So they'll have more first dollar coverage. But a thing that's often very common for the consumers we work with is that they have, and for these plans, as you know, if you're getting a platinum plan or gold plan, it has lower deductibles and lower copays, but you're going to pay more per month. They have higher premiums. The bronze plans have cheaper premiums. Silver plans generally have next cheapest premiums. But because most of our consumers are in lower income ranges, as you know, they qualify for certain special silver plans called cost sharing reduction plans, or CSR plans. And for people who are in particular income brackets here, based on where they fall into, based on the federal poverty level, it sort of unlocks particular kinds of silver plans. So if you're above 94% of silver CSR, if your income is below 150%, the only silver plans you'll see are these versions. And you can see here's plans sold in Pittsburgh, Pennsylvania, where I'm from, born and raised. That these plans, it's one plan. The base plan is the one on the far left, the silver, what they call 70% plan, the regular silver. If your income's lower, then you qualify for certain more generous silver plans. And you can see here the silver 87%, it's actually going to be more generous than gold plans. And the silver CSR 94%, so for people very low income, it's actually the most generous plans on the market. It'll have the most, the smallest deductibles, the smallest copays. It's even more generous than a platinum plan. And so if a consumer's lowest income, not only do they get bigger tax credit, but again, they tend to get the most generous silver plans available on the marketplace that is more generous than pretty much any other plan available in your area. I want to touch on one important thing related to preventive services. We talked multiple times before that if there's a deductible, you have to meet the deductible, and unless a service is waived, if you have an HSA plan, it doesn't exempt anything from the deductible. Well, the truth is one of the best things the Affordable Care Act did is it said any preventive service, for the most part, doesn't have to worry about deductible, don't have to worry about copayments, including for HSA plans. And so this is the one service that will always, always, always be exempt and will be $0 for folks. So that's an annual checkup. That's a couple age-specific tests you might need to get, some annual lab tests. We have heard over the years that not everything that we think is preventive sometimes falls into this. Sometimes providers will bill you for some things. Sometimes insurance companies will say, well, no, that doesn't count as preventive. You got to pay for it. If it's a lab test, that's some of it's regular, but then you have a heart issue and there's some heart stuff, it gets complicated. But in general, you can kind of explain this to consumers. It's kind of a great benefit of coverage that you're buying. Even if it's a plan with a big deductible, with no first dollar coverage, you at least get your annual sort of preventive care services free of charge. Another thing I wanted to highlight, because what we really saw in those first couple of years, and we've seen it a lot still, although a little less so, is consumers are calm, they'll see the prices of plans and they'll just have a hard time thinking that it's worth it, especially if they're younger, if they feel healthier, if their tax credit isn't big enough. And one of the things we can explain is even if you get a plan that has a big deductible, there's still some benefits of being a member of this plan. And here's a document called an explanation of benefits. You're probably familiar with this with your own insurance, where after you see some care, they'll send you a document that just summarizes how it was. It's not a bill, it's just a summary to explain it. And in this example, let's say someone went for a couple office visits and they got some labs done. And the doctor's going to charge on here how much they normally charge. It's their fee schedule. Again, not pretty transparent. You don't know what it is until you get it. However, the insurance company has what they call an allowed amount for each of those services for each provider, because they contract with each provider, or they call it a contracted amount. And even if you're in the deductible phase where the insurance company is not paying for any part of your care, you're actually paying that. The insurance company is not covering anything, but you're paying that allowed amount, the contracted amount. So in this case, you can see that you're kind of getting a pretty big deal by being a member, even though the insurance company isn't kicking in with any reimbursement for those bills. It's kind of like if you're a member of Costco, you're getting the discounted rate. And so this can be a huge value for folks, again, young, healthy, or maybe they're just someone on a tight budget. They want to buy a plan that doesn't have any first dollar coverage, but they're getting some benefit of being that member. They're getting the contracted rates. And moving on to benefits, there's a lot to talk about here. One of the best things about the Affordable Care Act is it really standardized the categories of benefits that every plan sold in the marketplace has to cover. And for the most part, it's pretty similar across plans. There's some variation across here, but for the most part, it's pretty same, with the exception of the one on the bottom, the pediatric oral care. So I just want to show 3 different plans that are sold in the area I volunteer in Virginia. And you can see the plan on the left does not involve any dental care. So even though pediatric dental care is supposed to be covered, because of the way the law is written, it actually allows coverage plans to not include it if there's separate standalone dental plans available for you to buy. And in many markets, there's a standalone dental option, and so these companies don't have to include it. The plan in the middle, though, chooses to include it, so it's sort of bundled in. And so if you buy that plan, your kids will have dental coverage. And the plan on the right from Kaiser Permanente, and it's true across the country for many areas Kaiser's in, they actually offer not just a child dental benefit, but they also include dental benefits for adults as sort of an added perk. It's not huge coverage. It generally covers some routine visits and then a little bit of basic care, so fillings and some other stuff at a discount. But it could be a huge benefit and a huge value for some consumers. And in fact, I've seen some consumers choose Kaiser as an option because they involve adult dental. And moving on to prescription drugs, you all are probably very familiar with the fact that one of the most important needs for many consumers, especially folks with health needs, is coverage for prescription drugs. And when you're looking on Healthcare.gov in that section, they'll have a dropdown that lists these 4 different types of prescription drugs: generics, preferred brand name drug list, all other brand name drugs on the non-preferred list, and then specialty drugs. And in general, it has an increasing value of what the copays are going to be, with generics being the cheapest and specialty being the highest copay or coinsurance you're going to have to cover. But not all drugs are categorized in this way by companies. Sometimes they have some generic drugs that are moved up into the preferred level. And sometimes there's even some preferred drugs that they drop down into that lowest tier, that generic drug level. So I often think of it better as considering it tier 1 through 4 or level 1 through 4, but you'll see each company label these tiers differently. Another thing you might see is that some plans have a separate deductible for prescription drugs. So any payments you pay towards prescription drugs will then count towards this deductible. Once you hit it, then you pay the copay or coinsurance. But most plans actually just bundle and have a combined deductible for both medical care services and prescription services. If that's the case, as you'll see here how I changed the text, it'll list it as included in plan deductible. So it's one deductible, doesn't matter what kind of services you get, all those payments count towards that deductible. After that, you pay the copay or coinsurance. But for many consumers who have prescription drugs, the most important thing tends to be, well, how is my drug covered? What do I have to pay when I go fill that prescription? And so there will be a link to view the list of drugs for each company. And some of them, like the one on the left, will have an interactive website where you type in the drug and it'll show you how it's covered. The one on the right happens to use a PDF. And so you have to search for it on the PDF. And you can see here, here's the Humalog. It's a drug for folks who are living with diabetes. And on the left, it's covered at tier 2 for that plan. On the right, it's covered at tier 4. So likely we'll have a pretty big difference in terms of what the copay or coinsurance is going to be. And that might greatly factor into what a consumer wants to choose. Now let's briefly touch on networks when it comes to health plans. So what are the providers available? And I want to talk about the different categories you'll see. And if you're a new person, then you might be unfamiliar with these terms, but there's an HMO, and then there's other options called PPOs or POS plans. And without going into great detail about them, we'll kind of cover how every plan will have doctors that are in-network, or hospitals or pharmacies. So those are your in-network providers. And then there's going to be other providers in your community that are out of network. And so those are sort of ones that, that insurance company hasn't contracted with. And if you have an HMO model, in general, it requires a consumer to pick a primary care doctor, a PCP. And then if you want to go to see any specialist or anything else, you got to get a referral to see those other providers. And you're going to pay copays or coinsurance, and the insurance company is going to pick up the tab, right, the rest of the bill. If you happen to go to an out-of-network provider, though, that HMO model does not include any coverage for that out-of-network doctor. You have to pay that full bill, and generally it's quite high. A PPO and point of service plan in general does not require any gatekeeper, any primary care doc. You can go to any doctor you want that you need to go to. It's a primary care specialist, whatever you want. And it includes some coverage for out-of-network care. However, the copays and coinsurance will be higher, and it has a separate deductible. So for someone who really needs to see a specialist across the country, a PPO plan might be a lot more advantageous, but PPO plans tend to be much more expensive. Now, in the beginning of the Affordable Care Act, we started seeing a new term called an EPO, which is an exclusive provider organization. And it's kind of hybrid of the other two models where you don't need a primary care doctor gatekeeper, but there's no out-of-network coverage. For the most part, the main takeaway from this is that PPOs and point of service include out-of-network coverage. The other two don't. I just want to show you how that might be different across different companies. So here's an example from several years ago in Omaha, Nebraska, where there's 4 different companies, and each company happens to have more than one. Some of the companies have more than one network, so they contract with different lists of doctors. And I just looked up in a 10-mile radius of a particular zip code in this area, how many primary care doctors they have, just to get a sense of the relative size or breadth of those networks. And you can see it's across the board. And we're used to thinking that a PPO, not only does it include coverage for out-of-network, it also tends to have more providers in network. But that's not always the case across companies. So you can see here that actually the smaller networks include some PPOs. The Coventry plan has 4 different networks, and it's sort of across the board, and the PPO has the fewest doctors among them. And then the bottom 2 plans, the United Healthcare plan back then actually had the most number of primary care doctors, even though it was an HMO. So the most important thing is kind of getting a sense of how each plan structures their provider network. And it's something that might be useful at the beginning of the year to get a sense of as you're leading into open enrollment. But again, like with prescription drugs, for most consumers, what they really care about is, how is my doctor covered? Are they in network or not for a given plan? And so on Healthcare.gov, you're going to have a link to provider directory for each plan, and that's going to take you to either a website, occasionally to a PDF, which is much more difficult to search. But you can type in the name of a provider and see if they're covered or not, which might greatly influence which company a consumer is interested in looking at to buy a plan. So that's the basic elements of health plans. Let's move on to the next section, which is trends we're seeing in marketplace plans over the past few years, and also what we see coming up for 2022, which is going to be a very unique year given the changes that's been made to the law and the more generous tax credits that consumers are facing. So the first thing I want to mention is, for the past few years, we're seeing a lot more of types of plans where the deductible equals the out-of-pocket maximum. It's a huge deductible, so it hits the out-of-pocket max. Once you've hit the deductible, you've hit the out-of-pocket max. And that's why when you scroll down and you look at what the different copays and co-insurances is, it's no charge. You hit the deductible, you hit the out-of-pocket max, the insurance company covers everything else. So this actually looks very similar to, say, auto insurance, where you cover a certain amount up front after an accident, and then the insurance company covers all the rest of the services needed. And so it's kind of like a catastrophic plan. And for some consumers, they're young, they're healthy, this plan might work. It's just in case of a major accident or illness. It tends to be the cheaper plans on the marketplace. But if a consumer has even some moderate health needs, this plan really puts the burden on them. And so it isn't necessarily as useful. But a consumer who has major health needs, and they're going to hit that amount anyway of $6,000, this might be a plan that does work for them because the premiums are lower. They're going to hit that deductible because it's a major health procedure they need, and then they cover nothing else they have to pay for. The other thing we're seeing is that we talked earlier that there's 4 different tiers of prescription drugs. Well, it turns out that's not always the case. Over the past several years, some companies are actually taking that generic tier and they're splitting it into 2 different tiers. One that has the lowest copay, one that has a slightly higher copay. And some are even taking that specialty category and splitting that into a preferred and non-preferred. And then I've even seen a 7th tier more recently. And so one of the things that makes it complicated is if you're looking at 2 plans with a consumer and you're looking at, well, how is their drug covered? They might be covered at tier 3 for both plans, but those tier 3s might mean something different if one of them has 6 tiers and one of them has 4 tiers. So it's important to make sure you're going in and seeing, well, how much is the actual copay for that plan for that drug? Similarly, some companies are tiering their networks. This is something I think is pretty common among several companies. So they kind of say they have a tiered 1 list of providers and they've negotiated probably really good rates with those providers, or maybe those providers are known for having really good quality scores. And so they say the copay there, if you go to that network, is lower. But if you go to one of the higher tiered list of providers, you're going to pay more yourself. And so I want to show you what that looks like. Here's an example from a plan in Philadelphia, Pennsylvania from a couple of years ago. And you can see if you go to a tier 1 primary care doctor, it's $30. And if you go to a higher tier, it's a little bit higher. So they kind of want to encourage you to go to that tier 1. But you can really see the difference when you look at this facility fee cost for an outpatient procedure. You're going in and getting sort of a procedure, a same-day procedure. If you go to a tier 1 doctor, not only is the copay low, the deductible also doesn't apply. So you could actually be paying not just a much higher copay, you could be paying significantly more if you go to a tier 2 or tier 3 provider, even though it's the same exact service. So if a consumer has a provider they're looking at, whether it's a hospital or a doctor, it will be important if there's a tiered network plan to make sure you understand what tier that provider's in. So now let's go to some trends we're seeing from this year and leading into next year because of these massive enhancements to tax credits. Not to mention what the pandemic did in terms of creating a virtual world. And one of them we're seeing is an example from a plan in Arlington, Virginia, where I volunteer, that's actually been proposed for next year. And they want to include virtual visits, telehealth visits. And I'm sure you all, if you've received care over the past year, you might have been able to take advantage of telehealth visits. And I know for me, it's been a blessing. I've really appreciated the opportunity to do it and have more virtual interaction with providers. So this plan is allowing that first dollar coverage, that partial exemption of the deductible for the first 3 telehealth visits. And then after the first 3, you get a $25 copay visit, but it has to be from a designated list of virtual providers they've negotiated. Deductible doesn't apply to any virtual primary care visits. So it gives you 3 free and then $25. You don't have to worry about the deductible. It's kind of encouraging primary care and encouraging telehealth visits, presumably in this case, both to ensure public health safety, so you're not going into the doctor's office, but it also might mean that they've negotiated an even better rate with that provider for telehealth visits because the doctor doesn't have to do as much stuff. They're not doing labs, they're using less time. And so it's sort of something that can be very beneficial, at least for consumers who are computer savvy. Another thing we're seeing is because the tax credits have gotten so big, thanks to the different changes to the Affordable Care Act under the American Rescue Plan, you are seeing a ton of free options, and mostly bronze, although some are silver. So here's just an example of in an area here where you have free bronze plans, $0 premium. So if you're young, healthy, why not enroll? And it's something over the past couple of years we were trying to do, and now even more so. And I'm actually showing you in this area, just scrolling down and looking, well, how many free plans are there? It turns out that it takes you to get to the 10th plan before you actually see one that has a premium. And that premium is $1.14. So there's just a lot of cheap plans available in the marketplace, especially in the bronze area. But as we talked about, bronze has big deductibles and may not have as much first dollar coverage or may have no first dollar coverage. So you're balancing what the monthly premium is with these other costs. And so again, it depends on what the consumer is looking for. But if they're, it used to be people would come in, bronze plan would be $100. They'd be like, what's the point? And they'd walk out. Well, now you can be like, hey, there's no harm in signing up, right? If you're young, you're healthy, you think you're invincible, hey, take a free bronze plan. Why not? In case something happens, you're covered. If you don't use it, you don't use it. That's fine. And then another thing we're seeing, which is actually unique to Milwaukee, and Adam and I were talking about this earlier, it's the first time I've seen this, is this concept from Molina is doing some 0 deductible bronze plans. And I've never seen that before. So here's the plan available here from Molina. It's only $38 and it has no deductible for the bronze. So at first I was very excited. I was like, how can a bronze plan have only no deductible? Well, when you actually go and dive into it, you see, well, the way they structured it is actually has pretty big copays. So they're saying, okay, no deductible. We're not putting it all on you for a certain amount, but every time you go to the doctor, you're gonna have to pay a lot more. So specialty visit of $150 kind of gets pretty close to what the full bill of a specialty visit is. And then you can see here, generic drugs at $27 is probably one of the highest copays I've ever seen for generic drugs. But you really see it with some of these other services. So $1,000 for an MRI, $1,850 for an ER visit, and then it's $1,500 per day for a hospital visit. So you're going to pay quite a bit. And if you get, a moderate amount of this care, you're probably going to hit that out-of-pocket maximum. So it's just a different model that's interesting. And we're curious to see sort of who's going to end up picking these plans. Another thing I want to talk about just visually is talk about what is these increased tax credits that are driving down the premiums for most consumers. What's it going to do to demand? And this includes not just, as you can see, the tax credits were extended not just to people below 400%, but also to people above 400% for the first time. So these are not actual values. This is just sort of like summarizing before the American Rescue Plan passed or before this past year. Most of your clients were probably lowest income. So people below 150% of poverty, they get a huge tax credit. The plans usually are pretty cheap, and they get those really generous CSR plans. So a lot of them would come in, a lot of them would buy. And then there's people who had slightly higher income. I think while, many of them still had good deals, maybe fewer of them bought just because, sometimes the price was not as good. And then even fewer probably brought in a slightly higher income scale. And then you really saw that probably very few folks bought, you had fewer folks between 250 and 300. There was no CSR options there. We didn't see a ton over 300%. And I don't know if that's the same for you. And then very few did we ever enroll that was over 400% of poverty. And I actually help a lot of my peers who are self-employed people around the country to help them sign up for coverage. And many of them have slightly higher incomes. But as a certified application counselor in Virginia, I can't remember seeing anyone above 400% because they didn't get a tax credit and those plans were quite high. And as someone who was self-employed for 5 years, I used to buy and I was fortunate to have an income that was pretty good, but those plan prices were pretty high. And luckily I'm obsessed with people being insured, and so I bought it, but it was a pretty big chunk of money. Now though, so now the rescue plan passed, the really generous tax credits for a lot more people. It also allows people who got unemployment, as you know, to be treated at 133%. So they're getting really generous tax credits regardless of their income. I think even more people now are going to come in these lowest income ranges or in these categories. And I think even more of them are going to buy. So be prepared for that increased consumer demand to your doors. And then I think the same is going to be true across the income spectrum. So there's going to be folks who have slightly higher incomes that maybe we are going to be even more likely to come and see you and more likely to buy. And that includes people over 400%. They may or may not come to you. They might go to brokers. They might, have other sources, but you might see them in the door, and you're going to be inputting income numbers that are much, much higher than you used to, and getting a sense that they might be more interested in plans that are more generous because they can afford more. So speaking of which, we're kind of wondering over the past few years, and certainly this coming year, are more people going to choose gold? And in general, I think I had 1 or 2 people I've ever enrolled in a gold plan. And now you might have significantly more folks. And that includes sometimes gold plans are even cheaper than silver plans because of different trends in the market. And so get familiar with some of the gold plans now. Here's some more work for you to do, because you might have some higher income folks who are choosing gold that might be beneficial for them, especially for consumers who don't qualify for CSR plans. The gold plans are going to have lower deductibles and lower copays. And the one thing I wanted to mention, which doesn't actually apply to you all in Wisconsin so far, is that because there's more tax credit, because they think there's more demand, because more people are going to buy plans, there's more health insurance carriers considering entering the ACA marketplaces in some states. And you might have had some plans that left the marketplace because they didn't think they were making money a couple of years ago. Now they're coming back. So there's going to be more options. In theory, that's more competition and more plan offerings. Sometimes we think too many plan offerings can be overwhelming and it's sort of option paralysis. But if it isn't happening this year in Wisconsin, it might happen in future years, depending on how the profitability is going for the different companies. So that's another thing to keep an eye out for. But now let's go on to the strategies for helping consumers so we can kind of integrate all this information.
Dave, I just wanted to confirm, so after section 3 will be Q&A?
Correct.
And then are the poll questions interactive? I cannot remember where they're situated in the presentation.
They are not actually, I apologize, but I don't know if they're going to post it on that, but we can walk through them if you want to post in the chat.
Yeah, if you want to do at least one of them, we have to do at least 2. So
okay, we can go for them maybe at the end of at the complete end before we go into questions.
That's fine.
Or actually at the end. We'll do it at the end. Great.
Okay, cool.
So let's integrate all this stuff. So when you're preparing for open enrollment, as soon as the plan options are released, and for some states that's before November 1. For other states, you don't get to see what's happening until literally the day things go live. But maybe if you're excited, you can stay up till midnight November 1 and get a sense of what these new plans are. Or maybe Adam is going to be kind enough to do some of this analysis for you. I really have to track what is happening, what's changed from year to year. So here's just the area I volunteer in, and you can see from 2018 to 2021, you can see sort of which plans are in. In 2021, we have a new company coming in. United Healthcare is coming back to the marketplace. And you can kind of order them by price. This is for someone who doesn't qualify for tax credits, who has let's say much higher income, but just getting the order of what the plans are in. And you can see Cigna is going to be the cheapest, United's coming in at the second cheapest, and Kaiser has all their plans clustered at the highest end. Because there's more folks getting much more tax credits, they might be buying plans. I used to say, get really familiar with the cheapest 4 plans, because many consumers are really buying the cheapest 4, especially silver. These are all silver plans. You can do this for bronze as well. You can make a table and kind of get a sense of what's coming up. Maybe just compare 2020 to 2021, or even just look at 2021, or sorry, next year, 2022. But now, because folks might be interested, they have sort of more purchasing power, they might be more interested in buying up. And so you might have to get more familiar, get really comfortable with these plans that are on the higher end of the marketplace and get familiar with how they're different and why some might offer value to consumers. And so not just tracking how the plans are going, but I'd say really study the plans. And some of you probably already do this, but if not, I'd print out the summary of benefits and coverage for each plan that's being offered in your area. Or at least have the PDFs downloaded on your computer now, since you might be doing a lot of virtual events and you can share your screen. And so just really get comfortable with these plans. Get a sense of what are their deductibles? What does it apply to? What is the copay, co-insurance? Is there any weird things they require? Like pre-authorization for some stuff. What are the generic drug copays? How does it treat mental health? What is the ER copay? That'll just help you when you're looking with consumers. So when they bring up what their needs are and have different questions, you might be more familiar with it without having to sort of study them on the fly during that first week of open enrollment. Another thing that might be relevant, as I showed before, you can kind of track how big are each provider network. And you can see here, in an area in Arlington, Virginia, I got a sense of the 4 different networks that were there. One company had 2 networks. And then there's 2 other companies, and get a sense of how big are they? What's the relative size of these networks? So I put in for each of them a 5-mile radius out of a zip code from that area. And I track not just primary care doctors, but a handful of specialties as well, and hospitals. So you can see there's a pretty big difference across these plans in terms of how many providers are available to different consumers. But for some consumers, they may not care how big a network is. They just want to know if their providers are in it. Or maybe if they have some providers, but then they want to see they had some heart issues last year. They were told to see a cardiologist, or they might need a surgery. They need to get a couple opinions. A bigger network might make sure that they have access to more folks who are available, who are nearby, who are more likely to have an appointment sooner. So that might be a factor for them as well. But now let's talk about how do we tailor a search to each individual consumer need. That's ultimately what our whole job is, because every consumer is different. And probably more importantly, every consumer has different priorities and different values. So two consumers might come in that have the same exact health needs and same situations, but they might treat things differently. So the first thing I say when you're structuring and approaching your appointment is this a renewal or a new applicant? Because if they're a renewal, well, they've gone through the process, they understand a little bit, they've had insurance of late, and you can kind of ask them first, like, how did that go with that company? Did they stay with the same plan over the years? So maybe they're familiar with it, or did they change and bounce around? Because usually the cheapest plans tended to be across different companies, and get a sense of were they satisfied with it? Was there any questions they had? Did they understand the deductible? I think by now people have become pretty savvy with using their insurance, but not everybody. So do you want to keep the same carrier? Or do you want to, go with the plan that either is exactly the same, or maybe it's been slightly tweaked? Or do they need to buy up and buy a more expensive plan that's more generous? Do they want to switch carriers? Do they need to switch doctors? All the above. But if they're a new applicant, then not only are you spending quite a bit of time on the application side, getting their tax credit correct and everything, they might have much more confusion or a lot less knowledge of how private insurance works if that isn't something they've been on before. And so you're going to probably have to spend a lot more time explaining how insurance works or fielding questions. So that appointment might need to be a lot longer. And the one thing I'd suggest is if you have a renewal, I would actually start by looking at plans first. If they have no major income change, and if they have no change in their family circumstance and nothing else that really would impact their eligibility other than just getting their new tax credit, I'd say start with the window shopping site, healthcare.gov/c-plans. And because that's what they're here for. They're here for getting coverage. Look at what the plans are, get a sense of which ones they might be interested in, then go in, quickly update their application. Barring any major changes, they're going to be able to go quickly and use that tax credit to buy plans. The next big thing is, as we've talked about, if a consumer has existing prescription drugs or existing doctors, that might really drive their search. So how are their drugs covered? Is their doctor going to be in network or not? Especially if they're looking at a different company because maybe the prices have changed or maybe the carrier has left the market, so they need to switch companies. Let's see if the providers are in network or not, and that might impact which option they want to choose. But remember that not everyone has medications or doctors, but they still might have health needs. Or maybe they're, you need to ask different questions to get a sense of what they need. And so it really is useful to say, like, well, how often did you go to the provider last year? Or did you need any medications? Or is there anything coming up that you might need to take care of that you haven't taken care of? A lot of folks, when they come, they've been putting off access and care. They just didn't want to go to the doctor because they, have to pay the full bill before they got insurance. And it turns out they have some major needs. And so, but that's not right now. That's coming up next year when they're going to get insurance or, and so getting a sense of, do they need physical therapy for something they've been putting off? Do they need a procedure, anything like that? And making sure you integrate that into their plan search. And then as I've emphasized over the past, for this presentation, I'm really, really interested in understanding what options are available with first dollar coverage. So when you're looking at healthcare.gov, as you know, you're sort of comparing plans across the different boxes and you're kind of scrolling down. And so here's an example, you're seeing the cheapest plans and the bronze plans. This is from years ago. Obviously the prices are much cheaper now. And you can see there's no first dollar coverage for the plan on top. And there's a little bit of first dollar coverage for the second plan. And you're going to, you can scroll down and you're going to start seeing plans that are, might have more first dollar coverage. So they're more generous, or they might have different deductibles. You keep scrolling down and you continue to find plans with more first dollar coverage, and deductibles might be higher, might be lower. But as you're scrolling down, the prices are going up, right? If you're organizing by price, if you're sorting by price. And so I kind of think of it as, imagine there's a rubber band. And as you're scrolling down, that band's getting tense and tense. And at some point, it's just not going to go any further. And I kind of view that as like, what's the upper limit of a consumer's price range? And so as you scroll down, there might be plans that have better value for a consumer. They might meet their needs better in terms of a provider, in terms of first dollar coverage, but you're getting more tension because at some point you're going to hit that upper limit. And so you're trying to balance that monthly premium with other things that a plan will offer them. So all of this is about trade-offs. It's about balancing different priorities and the cost and benefit of each option. And the first one, which is pretty common over the years, is comparing a cheaper bronze plan with a more expensive silver plan. And now you might even have a much cheaper bronze plan. You might have a free bronze plan, but they tend to have more a higher deductible and higher copays and cost insurance, cost sharing. So you're kind of saying like, is in this example, there's a $47 change in premium. Is that $47 per month, which is, almost $500 for the year? Is it worth it because of the lower deductible and because some of the first dollar coverage? And that'll be based on how often do they go to the doctor? Do they have prescription drugs? What categories of prescription drugs? And that'll help you get a sense of sort of what might fit best for that consumer so they can make that decision. And then as we talked about, consumers care a lot about whether their providers are network. And you'll often see that the plans that are on the cheapest end of the marketplace, maybe it doesn't have their provider network, but then there's a company that has a more expensive plan that does have their provider. And so in this example, it's again about a $40 difference in the options. And are they willing to pay $40 per month to be able to continue seeing their provider? It might be that folks are saying, you know what, I want to save the money. I'm happy to switch providers. But we saw some consumers, though, especially ones with very specific health needs, are very interested in continuing to see their providers. And when we did some surveys of assisters to get a sense of what consumers were doing several years ago, we found out that some people were willing to pay $50 more per month, $100, up to $150 more per month in premium to be able to maintain access to their provider because of their unique health needs. And then what it really comes down to is, I'm not sure how much we're seeing this now compared to when we first started a couple years, many years ago. But a lot of folks who come in who just, because the prices are so high, they just decide they don't want to buy coverage. What's the point? I think that'll be less this year because we're going to see a lot of free bronze plans. And again, we can kind of encourage folks to do it. But you might have folks who are higher income where, maybe the tax credit's really low. And so the plans are kind of expensive, even bronze plans that have big deductibles, no first dollar coverage. And you kind of want to reiterate, remember, there's preventive services that are free of charge. You're getting those negotiated rates. You're paying much less than you would be if you're uninsured when you go and get care. And then insurance is all about risk management. So you might get an accident or you might get a massive diagnosis, cancer diagnosis, something major. And if that happens, medical debt is still a major source of bankruptcy in this country. And so, we're kind of saying like, how comfortable are you going uninsured where something could happen? And, maybe for someone, $184, like in this example, is not worth it. They can't afford that. And so they're willing to take the risk. But that's something we want to make sure people really think through before they walk out of the appointment choosing not to buy insurance. And I think now with premiums coming down quite a bit, we'll have less of this. And that's very thankful because we really want to make sure folks decide to enroll in coverage. It's generally a good thing, not just to mitigate risk, because it might encourage them to go get an annual checkup and to go do some of the things that are more preventive. So now we can pause here and take the first round of questions before we go into the last section, which is the interactive one on Healthcare.gov. So I'm going to turn it over to Adam to see if we have any questions.
Yes, we do. And we have some really good ones, actually. So I'm going to go in order in which they were submitted. Okay. So this first one, I'm going to kind of give a short answer. And then Dave, if you want to elaborate at all, that's cool. Question was, how does the HSA plan work for people who are age 62, so they retired early? What advice would you give those looking for an HSA through their bank? And you mentioned pre-tax. How does this work in this case? So when I hear that, I think HSAs are pre-tax, meaning they put money into them and that will lower their effective income for choosing other plans. There are other options. They will be able to possibly get into other cost sharing ranges or find better silver plans, things like that. Dave, what do you think?
They might be eligible for better plans, but that's assuming there's an HSA eligible plan there that they can use it, which there are in silver, there's some in gold, but there's less options compared to bronze. Yeah. I will say, sorry, do you want to add to that?
No, that's true. That was just perfect.
I will say that I'm not an expert in HSAs. I've never bothered to do it because I have some frustration with HSA plans. I think they're cheaper on the marketplace, but they also made that second lowest silver plan tend to be cheaper. So people's tax credits were cheaper, and most people don't choose HSA plans. So I'm, kind of didn't appreciate that they dominated the market in the first couple of years. I also think it's really important to talk to it's more of a tax and financial instrument, not a healthcare instrument. And so if someone's interested in that, probably if they're higher income, because they, then recommend that they talk to an accountant or someone else to help them think through that. And I'll admit, I actually don't know how it applies to someone based on age, if they're at 62 or something else about retirement. I apologize. I'm not trying to say no one should get HSA plans. I just think that they don't always offer value to the consumers we work with.
Yeah, that's true. And the plans that we see that have that component tend to not have the benefits that we would normally want our consumers to get when they choose a plan. So they do look less attractive. I
will just clarify, we don't want our consumers to have any benefits because we're not allowed to tell someone what they should have. we feel that there might be things that are of value to them that we hope that they come around to, right? So
That is,
just clarifying that stickle point.
Nope, that's correct. We do not choose plans. We do not recommend plans. We help consumers understand their options.
Yeah.
So is there a preferred or recommended supplemental dental insurance to bridge the gap of coverage versus what is actually needed? I find all dental coverage in and out of the marketplace kind of lacking for adults. I think it's really hard for people like myself who've needed a lot of dental care. Dave, do you have any thoughts on dental care through the marketplace?
Yeah, super confusing, super frustrating to buy. I actually tried to get it 2 different years, and because of snafus around premiums, I ended up having to just drop it and get my premiums reimbursed. It was really frustrating. And I'm actually on the advisory board of the DC Exchange, and so you would think it shouldn't be happening to me. You find that what they do offer is 2 checkups a year and 2 cleanings, which is good. And chances are the premiums you're paying per month, it could be anywhere from $10 to $40. Depending on where it's at, it probably really makes it worth those 2 checkups. And then if you need stuff like cavities and some basic coverage, it offers, it might be you're paying 30%, it might be you're paying 50%. Again, it may add value, but they also tend to have pretty limited networks of who you can go see. So you need to get, it's just confusing. I don't recommend one way or the other. I think if someone has dental needs, it might be worth it, but it does add some more effort on our part, to max it.
Yeah,
and if you need major network periodontic care, root canals, other stuff, they tend to not cover much, if at all, and so that's where you
That's what I was going to say, because I have had personal experience with that. So just be careful, warning consumers that plan has an upper limit on how much it's going to pay. So once they start getting those really expensive needed services, they will start getting bills for those, and they should be aware of that so they can choose to not have those services or to go with other options, find free care, et cetera.
Yeah, I will say, for years as a healthcare advocate, we've been arguing for better oral health care, certainly for Medicaid, Medicare, they're trying to add that. I think we agree that integrating oral health is really important, especially for young kids, but certainly for adults. And we generally in this country don't value oral care enough. The question is whether these plans offer what you need or not, or is it better just pay out of pocket? But anything that can encourage folks to go and get preventive care, including a dental, I think is good. It's just, I'll admit, it's when someone wants to look into dental care, it's like whole other, add 30 minutes to the appointment. It's really complicated, and I just feel like we're not as well versed. Maybe there's places, organizations in your community that are better at oral health care that you can partner with.
Right. Thanks. Next question. This may have been more or less covered in a roundabout way, but I just want to make sure it's been answered. Client called the asker, and they wanted to explain the different insurance plans that their employer was offering them. And the question is, why would the insurance plans be presented as PPO or HSA instead of an HMO?
So each company offers different products, right? They call them different products. Some of their products might be an HMO. So that just means, it has that PCP you have to choose. It doesn't have out-of-network coverage. And then some companies will also choose to offer a PPO version that might look similar, but just offer out-of-network coverage as well. Or it might be different, have a different network. It might be structured differently. They're just different types of products. And so, if an employer is getting coverage, they might choose one insurance company and have an HMO option, a PPO option. They might have more than one company, and one only has an HMO option, the other one only has a PPO option. Marketplace is similar. We have, Marketplace is huge because it has tons of different options, much more than most people will ever get from their employer. And so it just really depends on what the products are, and then you're kind of tailoring that to the consumer based on what they might want.
And then there's a couple other questions that kind of loop back to that, because that question did include the HSA component. And the answer, I think, to these is going to be kind of, it depends on the plan. But the 2 questions are, is an HSA from an employer considered allowable coverage, meaning they can't go to the marketplace? And when they say can't go to the marketplace, I assume that means can't get APTCs through the marketplace. And then are HSAs really beneficial to consumers? And that's really subject to the individual consumer.
Yeah. For the first question, if that HSA plan offered by the employer counts as minimal essential coverage, like if it meets the criteria of the Affordable Care Act, then that is coverage. It's real coverage, and the consumer has an offer of coverage for them, and therefore is not eligible for APTC. It could be that coverage isn't great. It could be that employer doesn't cover a lot of that coverage, and so paying full price on the marketplace, especially, is worth it. I haven't seen that very often. And then, is an HSA worth it? I think someone needs to have extra money lying around to put into their account. And so that tends to not be the lower income families we meet. And then, like I said, it puts the burden on the consumer to cover all that care. it has some, like, you might have to get a separate credit card linked to your HSA plan, or you have to pay for it and then get reimbursed. It can just be a little cumbersome. It might be great for some, and I have friends who choose HSA plans, and that's fine, but they tend to be higher income. It also, the money rolls over from year to year. And so in some ways, we kind of view it as a tax shelter. It tends to really benefit wealthier people. It's a little regressive on the tax side. And so if a consumer wants that, if it makes sense for them, absolutely, like, don't discourage it. But I haven't seen it be very useful as an option for most consumers. And
Sure.
again, now that there's many free or bronze plans, if they're going to go bronze, chances are there's a free bronze plan with some first dollar coverage, and that might be better for them.
Yeah, and you said earlier, I think really well, that the HSA is more of a financial tool than really our ballpark in terms of that getting people enrolled in health insurance. So if people have a lot of questions on the HSA, you're not expected to be the expert in the financial aspect, and they should probably go to a financial advisor or professional accountant, etc. I like this next question. Why would an insurance company offer several options per metal category when the majority of consumers gravitate towards the least expensive? What's the incentive to do this, and why not just offer one option?
It's a business choice. And I think we saw in the beginning, most companies offered several, a handful to many. And then over the years, some of them just whittled it down because they saw that people weren't buying a lot. And they were like, well, we get a sense of what people want to buy, and let's whittle it down. Or they saw which plans offered the most profit, and they would just kind of offer towards that. And so I think it really just depends on in the market what happened. I think the other thing is, if you're in an area where a lot of companies are selling a lot of plans, if you're another company, you kind of don't want to just have one or two, because you want to make sure people are seeing your options and they're choosing you, right? Especially young and healthy people. So you're trying to do as many plans that might attract young and healthy people, because that tends to be where, in theory, profit comes from. There's no rhyme or reason. I think we kind of got a sense that, like, once you get over X number of plans, and I'm not going to say there's a particular number, but people have a hard time choosing across more than 7 things. If you're buying cell phones, you're buying a computer, more than 7 things is hard. And unfortunately, in almost everything we shop for now these days, there's somewhere between a billion and infinity billion options. And health plans, I think we're going to see next year a lot more. And so that's why studying them and getting a sense of, like, what are the plans that are really going to benefit consumers, or likely going to be the kind that they look for. It used to be it was just the cheapest 4 or 5 that most people bought. Now with this increased tax credit, I think people are a lot more is going to be affordable. And so you just might have to get more familiar. But again, if there's plans that don't include a hospital in your area that a lot of people need, or don't include certain health clinics, like, those are ones, not saying you exclude them, but that they might be less beneficial for your consumers. And so, you kind of get a sense of which ones might meet their needs. I do want to say we might need to get moving pretty soon, but if there's one more question, we can maybe take it.
I just wanted to point one thing out. I've kind of a running commentary in the chat for folks. And then I just wanted to mention the silver plans, with the APTCs are going to be cheaper than gold plans, and most often it'll be the best choice for a consumer to choose for themselves. But I want to point out, sometimes you'll find a gold plan and you want to look at the details of it, because it'll have major services listed as no charge after deductible, meaning they could hit their deductible and get a lot done without needing to go all the way to their out-of-pocket max. So you got to look at the details of the plans just in case.
Yeah.
I think we're good.
Wonderful. Appreciate it. Those questions are great.
Yeah, great. Thanks.
Smartest and insightful. This is why I said the Wisconsin folks are some of the best. All right. Well, why don't we move on to this demonstration? It's something we started years ago about recognizing that talking about the concepts are fine, but really walking through how this would work with real consumer scenarios might be more instructive. So we're going to look at some scenarios using Healthcare.gov. And here's the first example, which is a woman who's 32 years old from Madison, who makes $32,000 a year. And remember, through the course of a visit, we're hopefully uncovering from her what are her health needs. And for some folks who are younger, we often hear that they feel like they're pretty healthy. They don't use care much. They just want to get a plan that's cheap. They're really worried about cost. So we're actually going to go on to Healthcare.gov together now and look through what her options are going to be. So here's Healthcare.gov. We're going to go ahead and go to the window shopping site, Healthcare.gov/C-plans. And so we'll go ahead and put in her zip code from Madison in Dane County. And we'll put in her information. I'm just going to fly through this because most of you are probably pretty familiar with this. So we'll put in her age, and we'll go ahead and confirm her income of $32,000. As I'm sure you all are know, thanks to the American Recovery Plan, if someone qualified for unemployment through the course of this year, they get a massive tax credit. So yes or no. In this case, we'll say she did not, and so she's sort of treated like a regular applicant. This provision isn't available for 2022, so it's really just for someone coming in for an SEP for the rest of the year that you care about it. But you can see here, she looks like she's estimated to qualify for a $266 tax credit, but doesn't look like she's eligible for a CSR plan. So she's above 250% of poverty. Let's go ahead and take a look at the plans that are available for her in the Madison area. And right away, you can see there's a ton of $0 plans, these free bronze plans, thanks to this increase in tax credit that applied to this year. We can look at them and kind of get a sense of, these are free, pretty cheap. She mentioned no doctors or drugs. So why don't we get a sense of which of these plans might kind of meet her need? And one of the things you kind of look for is, first dollar coverage, as I said. So you're kind of scrolling down until you hit that rubber band. We might, maybe she says this plan has a huge deductible. It actually looks like a deductible only plan. And it's an HSA plan. Maybe that doesn't apply to her. She's not as interested in that. And we can scroll down and get a sense. The next plan, again, has a bigger deductible and has no first dollar coverage and really high copay for primary care doctor. We can scroll down here. Here's another one from the same company. It has a big deductible. It does have some first dollar coverage, but if you look here, this plan is called the Dean Focus Network. And if I scroll down, the next one is just the Dean Bronze plan. And the Focus Network tends to be a narrower network that they usually charge less money for. So maybe since it's both free, why don't we choose this one? Maybe she says this is one she wants to look at. And now we want to find if there's something else that might be on there. Let's see, is there any more free plans, but has other options that are available? So let's see. So we scroll down and here's some other plans available for the same thing, but again, really high deductibles and no first dollar coverage. So we're kind of just scrolling down. Now we are all of a sudden in the plans that have cost, in this case, $7, but no first dollar coverage. And we get down here to the group health plan. It does have some coverage that's pre-deductible, as you can see, but $125 for primary care doc, again, is pretty much what the actual cost out of pocket, not even a negotiated rate. That's pretty high. And we keep going down. We're just kind of getting a sense of, is there a plan that has some more affordability that makes sense paying a little more money? We come here to the bottom one, it's $25, and it has a moderately big deductible, but it has much lower copays for primary care doctor, and maybe generic drugs. So again, she says she doesn't go to the doctor that often, but maybe this is one where if she needs to go every now and then, this might be useful. So maybe she says this is one she wants to compare. But remember, because of the big APTC, those gold and silver plans might also be cheaper. So why don't we go up and actually filter at the top? Let's filter for gold and silver plans. Click on gold and silver and see what applies now. And the first thing you'll see is this is one of those areas where the gold plan in this case is actually cheaper than the silver plan options. And you can see here, this first one is about $80. It has a deductible of $1,500, much smaller, and much smaller copays here. And it has some first dollar coverage. And in fact, when I looked at this plan, the only thing the deductible applies to is inpatient hospitalizations. So everything else is exempt. So why don't we look at this one as well? So we'll compare plans here, and you can see that it'll let you look at each plan side by side and pull up their cost of care for other services. Now, I do think this is a pretty hard way to compare all this stuff. I mean, this is how we do it when we're sitting with the consumer. For our purposes here, we're going to go back and take a look at slides just by a comparison chart that makes it a little easier and put these through plans available. So you got your plan that's free, has a big deductible, but some first dollar coverage. You got another one that's a little more expensive, has a slightly lower deductible in the middle and slightly lower copays, at least for primary care doctor. And then the plan on the right that's more expensive, it's a gold plan, much lower deductible that really doesn't apply to as much. So based on these, we kind of want to talk through to get a sense of what are her priorities. She talked about just caring about the cheapest plan, but maybe in looking at this, she realizes there's some benefit to buying a plan a little more expensive. And through the course of it, we hope she can kind of understand and get a sense of which plan might be the most best for her. So what are her priorities? Maybe, it's balancing the cheapest monthly payment, which every consumer comes to the table with, but then also like, how are those deductibles and copays? Does she want really high ones? Can she accommodate high ones? Or does she want those to be lower? And then that first dollar coverage thing. So every consumer will be different in how they value each of these options. But through the course of talking to her about that, hopefully we can get a sense and she's able to pick the plan that best meets her needs. Now let's move on to the next example, which is a married couple from Appleton that makes $25,000 a year. And so let's go ahead and look through what their health needs are. And so maybe they talk about it through the course of this and mention that Jim, the husband, has diabetes and he takes a particular medication for it. Maybe he gets frequent lab work done based on that. And then maybe the wife has a particular OBGYN that she sees and really, really likes that doctor and would really love to be able to continue seeing the doctor. So we're going to go ahead back to Healthcare.gov and we're going to start over the search to see how their process would go. So we're going to restart and put in a zip code for where they live in Appleton. And then now in this case, there's 2 people. So I'm just going to fly through this. If they're married, let's say they don't have any dependents. And let's go ahead and put in their ages. And we're going to put in their income in a second. We're going to put in $25,000. We'll again say that they didn't qualify for any unemployment, so don't have to worry about that. And now you can see that they're estimated to get a tax credit that's pretty big, over $1,100. And when you scroll down, this blue box indicates that they estimate that they all also qualify for the CSR Silver plans. And in fact, based on the income we use, they are below 150% of the federal poverty level. So they should qualify for those really special CSR plans that are very, very generous, even more generous than platinum plans. So we often want to think about, maybe let's go look at those plans now. You can see there's some free bronze plans here as well, because their tax credits are huge. But they did mention doctors and prescriptions. So why don't we go up there first? You go up to the top, and we can click on this link to see if the doctors are covered and the drugs are covered. And in this case, they have both. So we'll click on those. And we'll begin by putting in the doctor so we can get a sense of, is that doctor covered by these plans? And we'll add that. And then let's go ahead and pick the prescription drug, that form. Now, often with prescription drugs, there's a lot of different doses, a lot of different formulations, there's extended release, there's others. So you need to get a sense of what specifically they're looking for. And ideally, they bring in their vial so you can make sure you're choosing the right one for their search. In this case, we're seeing it's the second one on the left, it's the 500 milligram oral tablet that we're saying. So let's add that and then continue. And now we're seeing the plans. And here at the bottom, it'll indicate whether providers in network or the drugs covered. You'll notice it doesn't say how the drug's covered. So you actually need to go through and look at the prescription drugs and see, is it tier 1, is it tier 3? The other thing is, especially in the first few years, this categorization of whether doctors are in network or not wasn't always accurate. So you tended to have to go back and double check it by looking at the actual insurance company's website. And I tend to recommend that strongly. And I'd even say if some consumer is making a decision really based on whether a provider's in network or not, and one company that they're looking at says they're in network, I would call the provider and I would call the insurance company and confirm that information. And I would even get the name of the person who said yes, that doctor's in network.
Yeah, 100%. That's what I said in the Q&A as well.
Okay,
great to have that reinforced.
Perfect. So let's get a sense of what makes sense. So we know they qualify for really generous silver plans, but free plans are really attractive to folks. So let's get a sense of what's available. Now, the first plan here is that bronze 0 deductible plan. And the copays here actually aren't as big as we saw from some of the other examples. So there are different options here, but you can see the first one actually has that no deductible. And so maybe let's choose this. They say, let's look at this one. Now we want to scroll down and see, is there anything else? And I mentioned that, sometimes you need to double check on the doctor directory. So let's go in here. Let's actually do that together. It says the doctor is not covered. Sometimes that's inaccurate. Sometimes the doctor is in network, but Healthcare.gov says there isn't. So we're coming here. We're going to go onto the Molina site and we're going to choose Wisconsin. And we're going to look for a doctor at pharmacy. And so we want to make sure we're choosing the right network and everything else here. So as the site comes up, it's going to make sure the plan or program here. We want to make sure we're choosing the Molina Marketplace plan. We'll put in the zip code, make sure it's the right zip code, Appleton. And now let's go ahead and put in the doctor's name because we want to see if they're in network, because it might be that actually they are in network for Molina. And when we do this, it turns out that Molina says actually no, the doctor is not in network. You can see up top, it says no results. So that confirms the information we saw. So let's go back to Healthcare.gov. Maybe they say, well, this is a free plan, has no deductible. They still want to consider it. So now we want to see, well, what other plans can we look at? And maybe they say, let's find one that has the doctor in network that's also free. So the next plan does not. We go here to the Envision plan. It also doesn't. And I double checked all these. And so the first plan that comes up is the WS Health plan here. Now it's a high deductible plan, has a huge deductible, but the drugs are covered, and I looked it up, and it's at tier 2. And the deductible here is pretty big, and there's no first dollar coverage. But this is something that maybe they're open to, I think, just to take a look at it. And so we might add this one to the list. But remember, they qualify for CSR. I think, we all want to make sure we're showing people CSR plans. So now we can go ahead and filter for both, not just CSR or the silver plans, but also we know which company includes their doctors. Why don't we select that company to get a sense of which plans both include their doctor and have lower copays. So you can see here, the top plan has a deductible of $1,250 that equals the out-of-pocket max. It looks like it's one of those deductible only plans. It's $189, so it's much more expensive. But as we scroll down, here's another plan that's a bit more expensive, but it has no deductible and copays that are a bit lower. I looked up the metformin. It says it's covered at tier 1, which is actually no charge for this particular tier 1 because it has multiple tiers. The other thing I'll mention is that we need to look at labs. And so let's make sure we go down and take a look at the labs for the cost of medical care. And the labs here actually no charge after deductible. And this plan has no deductible because it's a generous CSR plan. So labs are free. So even though it's pretty expensive at $225, maybe they're open to looking at this one. So once again, let's compare these 3 plans side by side. And we have a pretty diverse array of plan options. So let's go back to our slides and take a look at them. We have the free plan on the left that has no deductible, the bronze plan, but pretty high copays. And the lab services are $60, but it doesn't include the doctor. And then if they want to include the doctor, they either need to have the free bronze plan that has a big deductible and nothing first dollar, or they have to pay a lot more money to get a plan that has no deductible but includes the doctor. And so this is a pretty big, difficult decision about, like, if they want to see the doctor, then they need to buy a WPS plan. And right now, the WPS plans that are cheap have a major deductible. The ones that really, have the no deductible and much more affordability on the cost sharing is much more expensive per month. This is a pretty big decision. So we talked about those trade-offs, right? And so here we're adding a couple different priorities in addition to what was we talked about before. Now, is their drug covered? How is it covered? What tier is it in? What's that copay? And then how important is it to continue seeing their doctor? Is it $225 per month important enough to continue seeing their doctor, or are they open to changing to get a cheaper plan? Every consumer is different. We really need to defer to them on that. But hopefully in this process, we're helping Jim and Michelle choose the plan that best meets their needs. So now let's move on to the Rodriguez family, which is a family of 3 from Milwaukee that has $50,000. So they're a little bit higher in income, above the CSR version. But let's say the husband actually was on unemployment insurance during 2021. And as you remember, that means that they're going to get categorized in a much lower income level, so a much higher tax credit. Let's say they know that the daughter has asthma and sees a particular pulmonologist for her asthma and takes an inhaler, Advair. And let's say that the husband actually is considering a procedure he's been putting off, and maybe he heard that this particular, St. Mary's Hospital in Milwaukee is a place where they do it well. And so that's something we want to take into account as we look at their scenario. So let's go ahead and do their scenario. I'm running a bit short on time, so I'm going to go ahead and fly through this and put in their zip code here in Milwaukee County, and then build their household. In this case, they do have dependents, 1 dependent. I'll just quickly put in their incomes and ages. And now let's go ahead and put in 50,000, but you remember down below it asks, did someone get unemployment insurance? In this case, they said yes. So let's say it's the husband who got it. And now they're eligible for a very big tax credit, $1,150. And actually, when I did it without the unemployment compensation, their tax credit would still be pretty big, of about $1,000, but it is a $150 difference, which is not insignificant. It also makes them eligible for silver plans, much more generous silver plans. So let's go ahead and look at the plans. And we once again see that they have some free bronze plans. And we would do the doctor search. And so why don't we go ahead and quickly do the doctor search. Sorry for flying through this, but we'll put these in.
That's okay. After this this example, we got to throw out those poll questions.
Okay. And let's add that. Let's also add the hospital. I might actually just skip our process for going ahead and doing how we got to this place, if that makes sense.
And when you've done this a bunch, you'll be this fast at it too.
Yes. I want to say, so I'm just going to go through and click on the ones that make sense. I think one of the ones that, we're looking for a plan that includes the doctor. In this case, it goes down to a together plan. We chose this plan because it's a lower deductible and low copays. So I'm just going to fly through and not go through the justifications. Here's an Anthem plan that actually includes the doctor. It says it doesn't include the Advair, but that's wrong. It is covered at tier 2. So that's an unfortunate one. But let's once again, they qualify for CSR. So we want to make sure, they do look at some CSR plans. So let's add a filter here. And let's go with, in this case, since we know that Anthem includes, let's do the silver and gold, and let's pick Anthem. Okay. In this case, there's a cheap silver at $57. And when I looked at all the options, this one looked like one that they might be interested in. So let's compare this one. Let's go back to our slides quickly. Now you can see a pretty different array. So there's two free plans. The one in the middle has the doctor and network, but it has a huge deductible. They do get 3 primary care visits for $30, but that's a pretty big deductible. The one on the right, not that much more expensive, includes some first dollar coverage, but the deductible is only $100, and it includes the doctor and the hospital. I want to say in this case, let's say they decide that seeing the doctor is still important, so they want to look at the Anthem plans. So the one thing I want to compare is a lot of folks are struggling between what's best for them. And let's say that in this case, we can ask them how often do they get care? How often do they think they'll get care? And so I'm not able to fly through all this stuff real quickly, but let's say we kind of calculate how much would it be if they had this amount of care they need. The plan on the left is free. The one on the right is not free, but based on the different plan design, they'd be paying much less if they got the plan on the right, even though it costs a bit. Now, I actually did it in case they didn't get the unemployment. And let's say next year they won't get that enhancement. Now, the premium's a lot more expensive because they had less tax credit. But even still, they'd be paying about $2,000 less. And so this adds an additional prioritization for them, which is what's their actual out-of-pocket expense in the premium plus co-pays and co-insurance based on their actual likely health needs. So I know we're basically at time, but Adam.
Yeah, we gotta throw up the poll question, like a little pop quiz for everybody, and then wrap up.
Yeah.
But Dave, I wanted to thank you. This is really, really great information. I have everybody, you could see them, they're all clapping in their homes as they should be. And yeah, really dived into the different aspects of the Wisconsin questions, which I really appreciate. And then with some of the ones that are still outstanding there, just bring them back up at the office hour session on Friday, and we will get into some of them. So poll questions were up or are up. I saw them. Yeah, wait.
I'm gonna go ahead and read those, Adam.
I can't see them. That's what
Oh, okay.
They should be on my screen. Are they on the screen?
Yeah, I'll read it. Which of the following is true about a consumer's cost sharing payments to in-network providers? They will always count toward the deductible, or they will always count toward the out-of-pocket maximum, or both A and B, or none of the above. So that's the first one. Second one, platinum and gold plans will always have the lowest deductibles and copays regardless of an applicant's income. True or false? And there's actually 2 more questions here, folks. Bonus. Which of the following provider network types offers coverage for services at out-of-network healthcare providers? HMO, PPO, or EPO? And then finally, under an HSA plan, there are no services exempt from the deductible. True or false? So we'll give people just a little bit longer to digest that. I know we're a little bit over time, but really important information here. And yes, thank you, Dave, so much for all of this. Let's give people maybe 15 more seconds to do all that.
While you're finishing, I just want to say, as you know, I used to work at the Center on Budget and Policy Priorities, and after I left, they were kind enough to bring me back to do these webinar presentations thanks to an RWJ grant, and I'm very thankful to be able to work with my old colleagues. I love doing that, and I love continuing to do these presentations, and wanted to make sure you can see the link at the bottom, healthreformbeyondthebasics.org/events. Check it out. They're doing a lot more huge webinars, national webinars on a whole host of issues around tax credits, eligibility, all the changes. And so they have a bunch coming up. Please check them out. They're very, very helpful, and I hope they can be useful for that. I will just say then, let's move this over. Good luck. It's going to be a strange year, but I think it's going to be a lot better than the past couple of years.
Dave, can you see the poll results? Just wanted
yes.
You can just let people know how they did.
Sure. First one, the truth is actually option B. Because as we mentioned, if the deductible doesn't apply to a service, it doesn't always count. It doesn't count towards the deductible. So 1 is not true, and therefore option B is the only one. It does count towards the out-of-pocket maximum. Number 2, platinum gold plans, they don't always have the deductibles, so it's actually false because the silver CSR plans generally have the lowest deductibles. So these are a little tricky and nuanced, I apologize. And then the third one, for which of these options out of network, it's the PPO, you guys got it. HMOs and EPOs will never offer coverage for out-of-network services, so it is the PPO option. And then HSA plan, this one was kind of a trick question, I apologize. So it is correct that no services are exempt from the deductible except for those preventive services. So want to make sure we're very conscientious of that, because if a consumer does want to get an HSA plan, let them know that there's no deductible that applies or copays for preventive services. So that is false. I appreciate the 2/3 you got it. Good job.
Great. Well, thanks again. We thank you for indulging us. Hopefully this is really useful with these last 5 minutes. Go ahead, kick it over to Allison, and I think we were on a break. Thanks, Dave.
Yep. Thank you, guys.
Thank you. Yes, very much. Yes, we're on a break, and we will see you all back here at 10:45. Leave the link open, and we'll start our next session. All right. Thank you, everybody. Welcome back, everybody. We are done with our break. So thanks for returning. We are now getting ready for our session on increasing your impact. And, we know that enrollment assistance is the name of the game and the goal, of course, but we need to make sure people are aware of us and aware of the services that you all provide. And so much of that is done through outreach and partnership building. So I'm going to kick that over to Courtney to lead us off. Thank you so much.
Thanks, everybody. I hope you can see full screen slides and not presenter view. Can you see the full screen? Can somebody give me a good? Awesome. Thanks, guys. All right. Well, yes, thank you so much for joining us today for this session, Increasing Our Impact, Building an Effective Referral Network. Our goal with today's session is to share some specific strategies and techniques to build, manage, and maintain a diverse network of local partners to support your outreach efforts and facilitate referrals for enrollment assistance. And we know that lots of you on this call are rock stars in the world of outreach. So even if you just come away from today with a new way to think about the work that you're doing or a new way to talk about how you're conducting your outreach, that will be a success. But we also hope that you maybe come away with some new ideas and definitely some new tools to organize how you think and plan for your outreach activities. This is going to be just a little bit of a different session. We're trying out some new techniques today during this session. So we are going to be doing an activity. So if you don't have a pen or pencil or some paper around you right now, I would go ahead and grab that while we get started. We're going to try and do a sort of interactive activity, and we're going to have a guest star of sorts in Julia Garvey, who's going to help us out by entering a couple of questions into the Q&A so that you all can comment on those questions to kind of give us some feedback about that activity at the end. So we're really excited about this session, and I hope that you all find it as engaging and kind of different and inspiring as I've found in working with our panelists to get things set up today. So speaking of those panelists, I'm just going to run through a couple of introductions. I am Courtney, your moderator. I'm the Outreach and Partner Development Manager at Covering Wisconsin. And with us today, we have Justin Rivas, who's the Program Director of the Milwaukee Enrollment Network. Justin leads community health initiatives for the Milwaukee Healthcare Partnership, aiming to improve health outcomes and advance health equity through community-wide collaboration. In addition to overseeing community health needs assessment planning and Health Compass Milwaukee, Justin supports the partnership's Racial and Health Equity Council, in addition to serving in his role as program director for the Milwaukee Enrollment Network. And then we have Trish Sarvela, who is the development director at Partnership Community Health Center, and someone that has been on this conference in the past and a partner of many of you all on this call. So welcome back, Trish. Trish is a leader in public health and community development at the local, state, and national level. And her work is innovative, outcomes driven, and rooted in participatory and research-based needs assessments. She was a leader in the rollout of the Affordable Care Act marketplace here in Wisconsin and continues that work today with a focus on and expertise in community networking, collaborations with health insurers, and marketing and co-branding materials for marketplace enrollment. And then finally, we have Martha Collins, who is the Director of Advocacy and Outreach at Feeding America of Eastern Wisconsin, one of our key sort of cross-sector partners that we're going to be talking a lot more about today. Martha is a longtime resident of the city of Milwaukee, and for nearly 2 decades has dedicated her career to working for nonprofit advocacy organizations that focus on building power within marginalized communities. Martha has over 5 years of food banking experience and currently works with Feeding America Eastern Wisconsin, the largest hunger relief organization in the state, who operates food banks in Milwaukee and the Fox Valley. In her role, Martha leads advocacy efforts that make our state and national policy response to hunger stronger, more effective, and more just by influencing decision makers, engaging community voices in the policymaking process, and building political power in the communities served. So we have an excellent panel, and I want to make sure they all have plenty of time to speak. So I'll go ahead and hand it over to Justin. And then as you have questions, I'll kind of pop back in throughout and try to moderate those for the panel. So take it away, Justin.
Great, Courtney, thank you so much. I just want to make sure that you can hear me. We're good. Okay, great. Well, thanks everyone for having me this morning. I'm going to be talking about some network leadership skills in this first part of the session here on building effective networks. You can go to next slide, Courtney. I would normally say in a live conference setting that I know I'm in the session that's between you and lunchtime, so that's a dangerous place to be. However, it is a virtual world, so you can eat lunch, whenever you want. But we're going to do some different. I think the session will be engaging in that it's a little different in how we're going to think about things. And by that I mean we're going to think more about how we do the work that we do, and less on really in the weeds of content on the what or expertise of the work. And I think that that's important because it's really about some tactics. There's some other tools you could have in your tool belt, right? And this tool specifically is network leadership skills. And I'll get into really what kind of that means. But basically, I want to convey that the leadership part is not just for what we think of as capital L leaders or people at the tops of organizations, but leadership skills that makes every one of us on the call in the room today leaders. So this is really applicable tactics or tools in your tool belt for everyone to do within their work, within their organization, regardless of what I call positionality. Next slide. Okay, so just kind of stepping back a bit, I'm going to talk a lot about networks in different ways, but I think it's important, obviously, for everyone in the room why we think networks could be important for achieving enrollment goals or enrolling more folks or closing gaps in enrollment. And I think it's because we learned that networks are really effective, and this is through research and application in addressing complex social problems. And there's a lot of complex areas that intersect with enrollment specifically, right? So we can think of how poverty, discrimination, income inequality, even immigration policy are complex issues, and there's lots of organizations and agencies and those that are working in those spaces that may benefit our enrollment work. And that also that I think as we narrow the gaps even further in the work that we do locally in communities, it's really going to take this strategic approach, if you will, to closing those last percentage points, if you will, of the enrollment gap in communities. There's a couple good quotes on the slide here too from some network, I'll call them network minds in the field, but I'll let you read those on your own. Next slide. Okay, so who am I and why am I in any way credible about talking about what networks are? So in my prior role, I worked at the University of Population Health, the University of Wisconsin Population Health Institute for a County Health Rankings and Roadmaps program. And my specific role was around network strategy and implementing network science, but also translating it for local practice with organizations and individuals. And what that looked like was really helping folks build capacity to improve their skills, to expand their partnerships and networks by using a little bit of science, if you will. And then also thinking about how you can carry this network mindset into all of the work you do with other organizations. And this can be, and I think of this on a continuum, collaboration, coalition work, partnership work. This is all work in which we're working together to achieve goals. However, those sets of organization look different in how we describe them. And networking is going to be the most informal way we can think about how we connect, but also work with other organizations. Next slide. Okay, so in terms of sources of where this information comes from, or For some of you that get really into this, perhaps, these are the two main sources and the places to go from a lot of, they have a lot of toolkits and resources to use, but also they have a lot of the kind of research to back up what I'm talking about today. I think the content for today and both of these websites are, for me, fun because it's a really beautiful blend of kind of left brain, right brain. There's some analytics, there's some strategy to it, but there's also just kind of some creativity and open-mindedness in how we approach it. So the first one, Visible Network Labs. Visible Network Labs is out of Colorado University, Denver, School of Public Affairs, Center of Network Science, and they have the social enterprise built out that has a lot of great kind of 101s on this and also resources. And they even have tools that you can use to kind of measure and evaluate your networks as you get a little more sophisticated with it. And then June Holly has long time been a kind of figurehead in this network research at networkweaver.com. And she also has fantastic visuals. If you're a visual learner or want to share some of this content or work within your organizations on it, that's another great resource. Next slide. So quickly, our plan today is I'm going to talk about networks in a little more detail and what network mapping is. We're going to hear from some great experts in the field that are working on building their partnerships and networks. And then I'm going to come back at the end of the session and kind of work through that activity that Courtney was talking about, the pen and paper and old school drawing of drawing out some network maps as we think about it as it applies to our work. Next slide. Okay, so just to keep everyone engaged, we're going to roll with a first poll question here. And this is for you to just kind of think and apply just what I've talked about so far, just a little bit to your own experience in your organization. So how has your organization conducted its network and partnership work in the past, or how are you doing it now? And the four options here to think about and how to respond to this, right? It's just organic. It's kind of like who we're networking with, who we know, who we've had relationships with. Maybe it is strategic, number two, and those connections are kind of thought out and it's a process. Maybe it's strategically planned with people in the field of enrollment and also other sectors that are intersecting with your work. And the easiest option is you don't know. So we'll launch a poll.
Justin. And Mike, if you could go ahead and launch that first poll. So I think everybody can see these now, but it looks like we've got about 24%, about a quarter of folks who say their networking is primarily organic. Almost 40% who are strategically planning in some way, a little bit more kind of across sector, which is really interesting and exciting. And then about 38% that say, I don't know right now. So hopefully by the end of this talk, you'll have a much better sense or tools that you can start doing some more strategic networking or evaluating that network. So thanks, Mike.
Great, so I'll carry on. This is my cheesy slide on letting everyone know that since 38% of you said you did know if you're doing this work, 100% of you have the capacity to do it, meaning that you're probably already doing a lot of this work organically or naturally, and it's just a way to put some strategy behind it and intention, and also build efficiencies in how you are networking, but also how you're building partnerships to do your work. It really just takes communication skills, being a connector of sorts. I'm an extrovert, so I love doing this kind of work. But even if you're an introvert and it's not the type of work you do, then there are also roles for you to take on within network building, and we'll get to that in another slide. So everyone has the skill set, and we'll explore what's the best fit for you, given your own inclinations and your role in your organization. Next. Okay, so what do I mean by networks? Most people, when we talk about networks or networking, we really think networking for career advancement. Like that's the number one thing that comes to mind, right? We go to, we want to network to find a better position, or we're networking on LinkedIn, and that's the way we usually address it or think about it. And that is one way to think about networks, but we're going to really think, step back and think more broadly of how it is really just a visual pattern of relationships. But networks are different in that they can be really intentional, right? So like for the example of LinkedIn, you're thinking about who you're trying to network with probably, and you're reaching out to folks, right? The types of relationships can be very different though, and that's important, and utilizing the difference in those relationships can be efficient to getting your work done. The networks help us organize what we see in the relationships in our community, and sometimes this is abstract and it's helpful, which we'll do later, draw some things. And they can help us make the most of our own connections, right? So we might have existing connections, we might have connections we want to make, we might not know who we should be connecting to improve our outreach efforts. So these networks, this network approach or network mindset approach can help do all of that. And most importantly, it can manage relationships because we all have a fixed amount of time, and relationships require energy. You probably know that from your personal life and from your professional life. Next slide. So I spoke about roles, and some fitting better for extroverts, introverts, for all the above. And here's a couple leadership roles within your network work that you can think of, and maybe think of where you best fit, or maybe even think about who of your colleagues or your staff are good in these positions as well. So if you're kind of in the more of the building your network phase, or getting more connections with organizations, then you could really think of yourself as a catalyst, the connector catalyst. And that's really the person in the position that's really helping getting your network started, reaching out more, putting intentional efforts behind the work you're doing in community to connect. The network guardian is someone who may be a little more logistical and can help organize some of the activities of your network or that you do together. They don't have to be formal, contracted partnership activities, but just ways in which you're collaborating or connecting. The self-organizing project coordinator, and this is more on the application or action base, the bottom two here, is one who can really do, again, some more of that operational work of organizing the projects that you work on, or outreach efforts or events within the network. And then the facilitator too, the bottom right, that's when perhaps your local network that's working on outreach, and this doesn't have to be just your organization, but how you're collectively working together becomes a little more formalized. And that could be the individual and or the organization that's kind of really the center of that organized network. Next slide. Okay, so a couple key rules, factoids, ways to think about networks. More isn't always better. And I like this little infographic. This is from the Visible Network Labs folks that I was talking about. More isn't always better, meaning the more connections is not going to be the most effective all the time. And having really strategic connections and thinking about who those are and how you work with those organizations is most important. The way you're connected with different organizations or different folks in the community, those relationships can look different. And that'd be number two here, right? Not all ties are the same. You can have strong ties with some organizations, some folks, and you can also have weak ties that are equally effective. And those weak ties really will require less effort. So going back to the relationships take a lot of energy. I like to think of the figurehead of Visible Networks Labs, Dr. Danielle Varda will talk about this a lot. We all have a relationship budget. So we all have, X amount of time we can put into building relationships, doing outreach work. It's time intensive. It takes trust building, and that's we need to honor that and be strategic about it. So we may have less of our relationship budget we put into certain relationships versus more that we put into others that are going to be more strategic in achieving our enrollment goals. Thanks. Next slide. And this slide, we'll be sharing all the slides, but this one just goes into a little more depth on that. And I think the interesting part is that the weak ties versus strong ties I just talked about, they look really different. And I think frequency is a big part. So you can have a weak tie, someone you can probably think of this, someone you know at another organization. You maybe only connect with them, every 6 months or so, or on a quarterly call, but you can really tap into leverage their network and their organization to help you when needed, and vice versa. So sometimes that's a little more transactional. You don't have to have full, complete trust in these weaker tie relationships. I know that sounds kind of weird, but it's more because maybe you're not sharing budgeted resources, you're not contracting to do work, but you're really just leveraging your own connections with each other. The strong ties on the other side, of course, would take more investment, but that's where you can probably leverage more fruits as well too. Next slide. Okay, so 3 ways that I think that networking can help the group here. First of all, learning. You can build your capacity. I'm sure you already do this with your outreach work and your referral networks by sharing learning around the content issues, but also learning about the community itself to close gaps in enrollment. Sustainability. So you can use connections really to grow your work and your efforts, both programmatically and collectively across organizations. And a big part of this work is advocacy too. So by getting kind of a critical mass around policy issues, you can leverage your networking and your organizational networking to really think about what you can do in terms of moving the needle on any policy issues related to our work. Next slide. Okay, so here's where I'm going to get into the weeds just a bit on distinctions, and this is where it's really important, and going back to how we think about networks. So there's two main buckets, if you will, and I've talked about these interchangeably, I know, in the first 10 minutes or so. But the first way we can think about networks is at the individual level. And this is how we normally think of things probably, right? Like who I know, who I'm connected to personally. This is called egocentric network, right? And it's just thinking about individual people. The challenge is, and I think the pandemic has taught us, people move jobs and people change the work they're doing, and always staying connected just at the individual level can not be as fruitful for the organizational level work or the social impact work. And that'd be the second bullet here, right? So thinking at the community level, how can we leverage the connections of organizations to really achieve greater social impact in the work we do? This is rooted in some personal bonds, but is also through sharing, by sharing purpose between organizations, but most importantly, understanding that there's maybe mutual goals to achieve and how you can connect organizationally on that. Next slide. I'm not going to read through this slide at all, but I'll just, I wanted to drop it in here for those of you who are more interested in looking a little deeper into this distinction between the individual or ego level and the kind of community or eco level. But I think that in thinking about more of the multi-sector work we do to close gaps, thinking about some of the collective impact work that aligns with enrollment work, I think that it's important to think about this distinction and read through these perhaps later on. Next slide. So I'll hand it off now to Trish to talk through some examples, because I know I've been in the weeds of a little bit of theory and kind of context. And I think that once we hear some great examples from Trish, we'll be able to come back to applying some of these theories that I talked about. So I'll pass it along.
Great, thanks so much. Good morning, everybody. Just a quick check. I'm using someone else. I'm using Julia's desk to make sure that you can hear me okay. Am I good? Thumbs up, perfect. Justin, thank you so much for that framework, because I think it really positions my presentation to talk a little bit about the practicality of this. How do you take this networking work into another level? How do you look at it with a different lens? And how do you build partnerships through strategic outreach that sounds, you know, rather high end, when in fact, much of it is really grassroots? As I was preparing for this presentation, I really started to think about what would be a really solid practical takeaway for people around the table, recognizing that many people are coming from different sectors, they're doing different jobs, they have different titles and names: brokers, navigators, certified application counselors, assisters. And it made me think about a state conversation that we were having recently about what does it mean to give information to the consumer about who we are and the work that we do? What's our definition of a navigator? What does that resonate, and how does that resonate with someone in the community? And although that was really outward facing, the presentation today and the takeaway I'd like you to have is really inward facing. And as I was thinking about these words, broker, navigator, assister, I started to look, and if you know me, you know I love a good rabbinical read into a dictionary or ways to splice and dice words. And I consulted the dictionary, but didn't come up with the 5th grade vocabulary word, but looked for the nuance in the work. And as I found these, I was really inspired. And I was telling my team this morning that this was just what I was looking for this presentation, this moment of definition, where we took a word like assister, instead of just saying someone who helps, to look deeper into that and say, an assister is someone who contributes to strength, to assist in bringing up strength. A navigator may drive a plane or a ship or get you over to the new world, but really they conduct exploration. There's an exploration of life within navigation. And a broker, we move away from the Wall Street definition of someone transactional, to work that is a liaison. So as Justin was talking about the roles we play in the networks, I challenge you to look at your world with a different lens, from broker, navigator, assister, or whoever you might be, to say, not only are we defined by these, but the work we do is to conduct exploration, contribute to the strength of the community, be a liaison to create a healthy community through coverage and care. So this different lens that we're looking at opens up our possibilities to define what is strategic outreach, not by definition of our role, but by not only the certification that we hold as well, but the fact that we are not just certified, we are called, and we are called to action, to liaise, to explore, and contribute to the strength of our community. Next slide, please. I hope through this presentation, we'll have an opportunity to really become inspired, learn some practical strategies, listen to a bit of storytelling, and also walk away with this saying, what is my next action step? I can do this. I know I'm capable. Maybe I'm alone in a rural community with just me doing the work, or I'm part of a huge network in an urban setting. We all share many of the same approaches, the capacity, and the need to respond to something in the community, particularly when we look at people who have lost their insurance, had a change in income, never had insurance, weren't offered employer coverage. How can we help as individuals, not only ourselves alone, but as a movement regionally and statewide? So we're going to dive in a little bit about a case study of what happened when we looked at Medicaid and marketplace enrollment during our public health crisis. Next slide. If we go back to some framework that we always use, and it's a question whenever I start talking about this work, whether it's 10 people around the table or 227 on a call, every one of us knows someone who needs our help. Every one of us knows someone who is uninsured, who's been outside of care, who maybe has a chronic disease they're not taking care of, can't afford their medication, really needs to connect with the services that we're able to offer. How do we begin to look at this from a roadmap, though? How do we know who that someone is? One of my favorite slides to always go back to, and I have to always thank Kaiser Family Foundation for really laying out the social determinants of health. And we talk about this a lot when we talk about equity and engagement and community work, but really beginning to understand, where are these organizations and places in our community that we can work with? And what are the barriers and challenges that many of our applicants, families, patients, community members face? So when I look at this SDOH chart, it's more than a chart. It's a call to action for me. And if I were to put on my lens of a community developer and look at this, and I encourage all of you to do so, and when we get into the activity, I think this will be really helpful, to say, in your community, who's working around employment? Who's working around debt? Who helps with medical bills? Who's involved in housing? What's your transportation network looking like? Are there people working around literacy, adult literacy, ELL, early childhood work? As we look at these barriers that people have to care, things that impact negatively their health, and ultimately sometimes their ability to engage in coverage, there is a direct line to how do we address people already serving populations who are in these sectors, particularly when we look at, and we'll hear about Feeding America's great work, hunger, access to healthy options. How does all of this tie into health insurance enrollment? Because as we look and listen to what Justin was talking about with network building, as we want and need to address social determinants of health, we need to look at things in a community and social context and figure out, how do we engage? How do we make that difference? How do we conduct exploration that's going to build resiliency, trust, engagement at the community level, so we can really, at the end of the day, impact health outcomes? Because as we all know, everyone knows someone who needs our help. And by us being involved in their lives, this work becomes transformational. This work becomes more than, and we've known this since 2013 when the Affordable Care Act rolled out, this is so much more than filling out a form and getting someone coverage. This is increasing life expectancy. This is engaging people in health. It's helping them be better students, family members, community members. Employability increases. How do we really look at this as a way to change and engage our community? Next slide, please. So as we talk about this, the story I'm going to tell you is a bit of what happened in our community when COVID hit. We go back to March when we were all instructed to shelter in place, and our community group got together and we addressed the problem. The problem was, what were we going to do with people who were homebound, people who were sheltering and had healthcare needs or had hunger needs? How were we going to reach them? So we came together with a community solutions team, and I love our call to action, which is in it together, stronger than ever, and needed to come up with quick solutions. So who came to the table? Public health, our local county government, our healthcare providers, our hunger relief organizations, many nonprofits, the ecumenical community, and transportation. And we asked ourselves a question: what was going to be the most impactful issue that people were going to be facing during a pandemic? Well, it was an easy answer in my mind. People were going to need access to health insurance coverage, because if they were losing their jobs or having a change in income, they wouldn't be able to get their medication if they needed to be hospitalized. All of these things, when you're looking at a public health crisis, are a direct line to health insurance enrollment and to access to care. So as we identified this problem, up bubbled a community access team that really wanted to not only look at health insurance enrollment, but we needed to look at, what about getting people to their doctor's appointments? What about transportation? What about pharmacy? And how could we then begin to look at this, not just with information gathering and solutions that we were going to give the community? We needed to figure out ways to engage the community equitably in languages and literacies that people would understand, so we could move forward. And this was the beginning of problem identification to community solutions. Next slide, please. So as we started to do this, and clearly one of the most academic strategies that I always like to talk about is my engage and mingle. And that may not be in any of the tomes of research, but in my mind, engaging and mingling is the opportunity that we have to get into the community at any level, at the grassroots level, at the policy level, at the advocacy level. How do we bring our message forward? And what is the message that we need to bring forward? So the first step is to really take a look at your community. Who's around you? Who do you know? Always start with you. In my world, who is in my universe? Yesterday, I was doing a new staff orientation with people coming onto partnership, and I gave them our enrollment cards, particularly this lovely one that we have here. And I said, each one of you knows someone who is uninsured possibly or in need of care. I'm giving you these because you're now an ad hoc member of our outreach and enrollment team. When you go to Quick Trip, could you put this up on the bulletin board? If you're picking up your child at daycare, is there an opportunity to leave this with the director? How can we help people see that this isn't something external, but the work that we do is internal, and it impacts everyone around us and everyone we know? The next piece would be always to find ways to partner. Make new friends. I tell this to my kids when they go out the door every day. Remember, be kind and make a new friend. And it's kind of at this point a little bit old, but in this type of work, we always need to reinvigorate relationships, reconnect with people, and find someone new. Sometimes it's the same old people sitting around the table, which is great, or sitting around the Zoom, but we're not moving in any direct way. Let's think about how we can engage those new friendships and new relationships. Many communities already have coalitions focused on early childhood, or school coalitions, or whatever they might be that's relevant in your community. We don't need to start a brand new health insurance enrollment coalition. Our message can come to others. How do we make that opportunity relevant for people so they want us at the table? Not only want us, but need us at the table. Because if you're at an early childhood coalition, what comes to my mind is young families. Ooh, maybe they're 300% below poverty. Their kids could be on Badger Care. Maybe the dad owns a small business, or the mom is starting a new opportunity and isn't offered health insurance. Always ways to find ways to engage and mingle and make that connection to enrollment. Make outreach a part of your day. Our phrase is, what's in your trunk? Do you have a little bag full of stuff? So when you're out there at 5:01, when the day is over, but meet somebody at a soccer game, at a bar, at a place of worship, here's some information. Let me pass this along. And I think for me, one of the most important pieces is not to be limited by your title. All skills are welcome. Whether you're out there at an executive level or this is your first job, that doesn't matter. The mission and the message of getting people connected to covering care works for everybody, and it works for all skill sets. Also work the crowd, make your message relevant. And I always talk about what's the vocabulary you're using. So if you look at the slide or the picture over here, it's a Taper's Barbershop. It's an African-American barbershop in Appleton. And we were doing a COVID-19 vaccination clinic there. Now, the vaccine in our mind, fabulous. Everyone should be vaccinated. We wanted to make it barrier-free, engage the community where they're at. But also, what an awesome enrollment opportunity, because here we are at a small, locally owned minority business full of barbers who were self-employed with a business that's unable to offer health insurance, young men who traditionally don't access care. How can we get the message to them? Right then and there, there's opportunities to engage. Find out what vocabulary works with that group that might be very different than the vocabulary you might use with childcare providers or other types of business owners. So we found that this was a great strategy to always look for opportunity. And let creativity and innovation guide your approach. There is no one size fits all, and there's no right way of doing it. Enrollment is never extra. It's central to everyone in your community. And you can talk about this at a high level where enrolling more and more people will really help improve the community's well-being, or at the very much individual level that you are changing the life and health of that person sitting in front of you, who maybe will go get that mammogram or maybe take care of that diabetes now because they have a pharmacy coverage. There's ways to make this central and to make this powerful. Next slide, please. So as we were going through this, the coverage to care at the COVID-19 clinics became something that was a community solution. Back in March, when we were really struggling with the pandemic, we were episodic in what we were trying to solve for. Solve for that transportation issue, solve for that coverage issue so people could get the medication, or their food issue. Always stay with what is that need in your community, and then how can we make health insurance become part of that? And it really comes together with getting the right people together at the right time. And if that's not about equity and inclusion, I don't know what is. It's not about us bringing the message to tell the community what they need, but finding ways to engage the community, or as Justin talks about, the networks that are out there, so this becomes manageable and relevant. But moving beyond just the equitable communication and the access to the information is really that action. And that action that goes back to that statement of everyone knows someone who might need your help. How do we act on that? How do we engage? I love these two pictures right here because they're the top one. And for you media people, yes, we have a media release on the family, was at our Vacuna Fest. And here they were, our patients who came out, every one of them with an enrollment challenge. Someone needed to be on our sliding fee scale because they were ineligible for coverage. Someone in this picture was working part-time and didn't have coverage. The kids needed to go on Badger care, but here they were getting the vaccine. And they also had a few bills at the hospital and needed some access to some other services. So we were able to not just be here with a flyer that talked about open enrollment, we were able to be here as assisters, navigators, and even brokers to be liaisons, conducting the exploration in the community and contributing to the resiliency and the strength and really the power of change to make this work. Next slide, please. As we look at the next pieces moving forward, and this is just a little snapshot of some of the work we've done with our COVID-19 vaccine clinics in different sectors of the community. One was with a community-based organization where I'll give a shout out to our team who, as we were doing this vaccine clinic, we had all of our enrollment and partnership stuff there. But that same day, St. Joe's Food Pantry was doing food distribution. So there were two of our members out there with creatively decorated paper towels with our enrollment cards, talking to each car that was going. Not a sell, not giving anybody something they didn't want, but again, being there as community members with something to offer, a smiling face, a warm hand, and an opportunity to say, we're here to help. A way to bring this message that builds capacity and builds strength. Vacuna Fest was a remix of what used to be Latino Fest, but due to safety, Latino Fest was canceled and we moved it to Vacuna Fest. We framed this as not just the dose of the Pfizer or Johnson & Johnson vaccine that you were getting, but again, a celebration of bringing the community together to identify solutions, build on resiliency, create the opportunity for conversation, and really, again, celebrate. We did work in the Hmong community at the Longchang Market, where we were able to really engage hundreds of local Hmong families to connect them not only up to, again, the vaccine, but the multiplicity of services that the community has. A small one that we did towards the end was at a local Pentecostal church where the pastor was very adamant about making sure that his parishioners were safe, but also that they had access to healthcare and coverage. And from that, next slide, please, we were able to move into working, and the pastor is on the top slide, the African-American gentleman, who also runs a methadone clinic. So from this, and when we look at, I always look at strategic outreach as concentric circles, that it begins small, it begins with me, or it begins with you, and it grows and continues to grow. And this exploration that we're on at the level of the community is endless. So as we're at the methadone clinic and the sun is rising around 6:15 in the morning on the side of 41, and people are coming in all shapes and forms to get their methadone, here we are again with our enrollment bags, our information, our team to provide vaccines, but also to link people up with services. A woman comes over and she says, Marketplace Insurance saved my life. I'm a realtor. I've been in recovery. I don't get opportunities to get health insurance. I enrolled and you guys helped me enroll. And now I'm sober. When I think about the power of the work that we do in someone's sobriety, their ability to be employed, their ability to connect with their families and their friends and live, as we hear the phrase, their best life that they can, that's powerful work. The picture below is another member of our team, Amber, and the CEO of the United Way at a mobile home park. Again, a place where go where the people are, be who you can be for those community members. Again, vaccination, but also all sorts of other things to engage. Every person's face here, every person's life is an opportunity. It's an ability for us to say, we are not just certified to do this work, but we are called to do this work because this calling allows us to participate in change. And this change really creates that healthy community. From 2013 to today, when I think about the impact that the ACA has had on people's lives in our community and in our state, in our nation, it is powerful work that we're doing that starts again at the community level. And I think just to close this with, and many of you are probably very familiar with this quote from Maya Angelou, but I think if anything to walk away with, wow, we can't do all of the stuff that partnership does. We don't have the resources. We don't have the people. We don't have the snazzy purple bags. What you do have is the ability to connect, to be kind, and to make a new friend. And as Maya said, I've learned that people will forget what you said. People will forget what you did, but people will never forget how you made them feel. And this work about relationship building and strategic outreach isn't about always the content or the flyer. It is about how you connect with people to be a participant in their change in an equitable and sustainable way. And this is where the inspiration comes from. So as you look at this session and the next part that we're going to be talking about, around, mapping and creativity. Know that you have the skills. You can look at your community. You can come up with a practical solution and come up with a next step, and you're empowered to do so, because not only are you exploring, you're a liaison, and you're contributing to the strength of the work that you do individually and we do collectively. Thank you very much.
Thank you so much, Trish. See, if you're not inspired by listening to somebody that's that inspired by their work, I don't know what we can do for you. So thank you so much, Trish. And speaking of, cross-sector collaboration and thinking about who's in your neighborhood, who's doing this type of work and impacting health, in a broader sense, we're now going to pass it over to Martha to talk from her perspective as one of our cross-sector partners at Feeding America, Eastern Wisconsin.
Thank you so much, Courtney and Trish. Amazing, as well as you, Justin, for setting the foundation for us. In that first poll, what I'm going to talk about, you will notice or see really quickly, I selected the option of strategically plan to make connections with other organizations in my field and other sectors that influence my work. So that was my poll one option that I selected as it relates to the way I go about networking and in my role within Feeding America Eastern Wisconsin. Again, welcome to everyone. And I love the Maya Angelou quote. It speaks directly to the work that we're doing, Trish, all of us in our personal and our professional lives, to make sure we remember how we make people feel. And the work that you have done has been amazing. And I'm just glad to be on this panel with you and Justin both. Next slide. So the 5 steps to building an effective impact network. I wanted to kind of reiterate and highlight some things that Justin has said prior at the beginning, just as a reminder before we go into the activity. So these 5 steps really explains the networks. I'm going to throw another term at you all today, network entrepreneur. He mentioned network facilitator and different descriptives as far as network, but clarifying your purpose. When you're bringing a collection of people together, what is the reason? Why are you doing this? What is the ongoing endeavor that you're trying to accomplish and achieve? It should be very clear. You should be able to identify the right partners when you have that clarified purpose. And also convening the right people means representing all parts of the system. Oftentimes it's said, being inclusive, who's missing? Who's not at the table? Who have we forgotten that we may not normally work with as it relates to our egocentric and being more ecocentric has been mentioned, right? Cultivating trust. So, you can't do this transformational work. You can't have a strong impact in the communities that you serve if you don't have authentic relationships with people. And again, that's why this all starts at the center of you and your direct contacts and who you are comfortable working with. And it kind of expands from that point. But being able to have that trust that doesn't mean control. Trust that means we're going to get the work done. A quote that I've heard before is, "It's no permanent friendships, just permanent issues," right? And we have big missions we're trying to solve. In my organization, our mission is to solve hunger. That's a huge mission to solve. And we know we can't go about that doing it alone. So you want to coordinate actions in order to do that, by identifying and coordinating ways that is already happening and leveraging it. Why reinvent the wheel? We heard the amazing work that Trish is doing with her organization up in the Appleton area. This is some person that I want to stay connected to. I want to expound on the work that they've done in the Milwaukee area, in the Green Bay or further north area. And so I want to coordinate the actions and efforts so we have a greater impact. And then the last, collaborate generously. Sometimes if you have small children, they want to take their toys out of the sandbox and hold on to it themselves and not collaborate generously or play well with others. It's not a transactional type of relationship you want to have. It's a friendship that you want to build off of, and knowing in mind that's a bigger goal in mind. So the next slide, network entrepreneur. The single most important factor you don't get out of this webinar today is that in order to successful collaborations, it's got to be based on trust and relationships of all participants involved. And many of the collaborative efforts ultimately fail to reach their full potential because they lack a strong relational foundation. So, looking at what is a network entrepreneur, I really love how the Stanford Social Initiative Innovation Review have really explained it. They ensure that it's systems level and it's collaborative, right? It's authentic relationships that's built on deep trust, and it's fostering a culture of distributed leadership. So the example that I'm going to talk about today really came out of the hospital, came out of Children's Wisconsin, but how it had this rippling effect of a larger pilot, that there's no one helm or one organization that owns ownership of it, and that we're all network entrepreneurs, the term entrepreneurs, bosses within this work that we're doing. Next slide. So our guiding principles, again, trust, not control, humility, not brand. I love the three ways that Justin talked about how we can network and help each other, was learning and sustainability and advocacy, and being able to do all of these things and not being in one hub, and that it's mission and not organization. And so this all is kind of, it's going to be touchy-feely or feel kind of cliche, but it's all comes from like a balance of power and love. And Dr. King talks about that. What leaders, when they ooze these guiding principles, how the power to get things done with love makes all the boats rise. And you see the successful successful collaborations on partnerships or projects that implement these principles. So let's talk a little bit about it. Next slide. There is a project that we launched in 2021, Feeding America, along with Children's Wisconsin, Wisconsin Medical Home, or Children's Health and Alliance of Wisconsin, and then two partner organizations, Freedom's Community Ministries, Freedom's Food Pantries, and the Salvation Army. And this food insecurity and health pilot is so powerful. Trish talked about looking at transformational change and looking at some of those social determinants that when they brought their group together during the height of a global health pandemic, it wasn't just focusing on the one thing. Okay, let's look at health or public health. They brought in transportation. They brought in, tons of nonprofits. They brought in all these different groups to get to that core central common goal that everyone was experiencing, was feeling, and wanted to impact in a meaningful way back in March 2020. And so that was the same guiding principles, the same idea, the same concept with launching this pilot this year. We know many individuals struggle with access to food, and the health systems really wanted to take this idea of meeting people where they're at. So we already have people coming into our clinics, coming for healthcare, that we know are food insecure. But during our intake process, we're not asking the questions. We're not asking the right questions. And once we do, revamp and change how we're doing our intake and ask those questions and identify food insecurity as being experienced amongst individuals and families, where are they going to go? You kind of think of the chart, yes, go this way, no, go that way. Where are we going to send them? Because this isn't necessarily our wheelhouse. We're navigators, we're assisters, we're dealing with enrollment as it relates to healthcare. But where do we send folks to get not only food today, but in the long term, as well as other issues that may come up? And so it's been, again, a real blessing to be a part of this project, because not only we know it's twofold. We're not only helping someone obtain adequate health care, but also food that they need. And so next slide. This slide really gives you more of a visual of the work that we're doing. And again, as Justin had mentioned, how the networks can help in three ways: that learning piece, that sustainability piece, and that advocacy piece. Oftentimes, we know the intersectionality of a lot of these different social issues, but everyone works in their silos. And so this really became like a learning community project for all of us to understand what Children's Wisconsin was doing, and what was Salvation Army doing, and what was Feeding America Eastern Wisconsin doing. So we have these weekly sometime meetings, monthly meetings, where we come together and we just learn about the different network partners, and exactly the work that they're doing and the projects and initiatives they're doing outside of the food insecurity pilot. And that has been very helpful, and has been a way for us to build our network as an agency, Feeding America, because now, we're partnering up and learning more about different groups that we hadn't worked with before. And it really creates the sustainability piece, as far as, if we're going to do this transformational work with folks and get them help today, how can we impact them and help them in the long term? And, for instance, it really also, the last piece, the advocacy, helps lift up the policy change. So we know it's a number of groups have been working on Medicaid expansion for a number of years, and has come to so many roadblocks with the administration. And I always say to staff, it's great. We can scream from the rooftops as it relates to food insecurity, but to have a story from a self-advocate, from someone that's directly impacted, and sharing that story could change minds and hearts as it relates to the decision makers, to the policy makers. And so that advocacy piece is also very powerful in the work that we're doing with this pilot and Medicaid expansion, talking about college hunger, talking about senior hunger, and being able to be good partners and collaborators to lift up both issues for each other. And so, again, this kind of gives you kind of a visual where you can see and learn a little bit more about the project. Next slide. So this is kind of just an agenda I wanted to share with you all, a timeline. I want to share with you all about the actual starting of planning the project and what the activities we've gone through thus far to get to where we're at. So, of course, initial partner introductions. That, again, that's back to those learning communities. We may assume and think we know what Salvation is doing, or they may think they know what Feeding America is doing. But, hearing what each other is doing and really getting a better understanding. And it also helps us to identify who is missing. Who else needs to be at the table? Who else do we have partnerships with that this would be a good fit in this project or outside of this project? And we have these quarterly electronic surveys that helps us to check in on a regular basis on some more of that 30,000 feet view level of the work that we're trying to change. We have, again, the learning community calls and discussions regarding the evaluations, the findings, the next steps. Oftentimes we do these projects and we don't take a chance or time or opportunity or carve out opportunity to really look at the data and see the impact and learn from our mistakes, so that our next steps are changed and we do things better. And so it just kind of wanted to give a screenshot of our timeline. Again, some additional organizational partners, Impact 211 and others that are at the table with us. And then just kind of an activities list of when you are in these group settings and these collaborative type of efforts, what are exactly are we doing, and to help us to get to the bigger work. Next slide. So building a resilient network for the long term. Again, this is just a list of people that have been also included that wasn't the core list of folks that I had mentioned before. And I love quotes. And this quote really resonated with me as I was putting this slide together, which it just says, when the best leader work is done, the people say we did it ourselves. And so it's not, again, that hub or that one organization that is the leader, that is the boss. It's all of these groups, it's all of these partners. And oftentimes you may have strong relationships, again, stronger than others, because you will have relationships before, if not at the beginning, definitely at the end, but you may not have the same priorities. You may, again, go across sectors, but it's the commonality, the common goal was getting people access to food, getting people access to healthcare. And these folks here have said, we stand with you, we want to support you, and we're going to support you. We're going to help with referrals. We're going to help when receiving referrals, to helping people make sure that they get what they need during their crisis. Next slide. So some of the short-term goals that came of this pilot was, building again stronger relationships. I can't say that enough. Learning about additional resources available within the community, understanding the barriers to food and healthcare access. Oftentimes, we might swoop in with the savior syndrome and think we know what is best for community with our experience, with our titles, and that's not the case. We need to. Sometimes you got one mouth, two ears for a reason. We need to listen and listen from the folks that are being directly impacted of what they need. They have no problem with expressing and letting you know that. And then our jobs is to make sure we try to help them meet that need, right? And so really getting a better understanding what the barriers are, sharing information with each other. As I mentioned, we work in these silos and oftentimes don't share information or share what's going on, just keeping our heads down and getting the work done, but just really carving out the opportunity and space for folks to do that. And then creating a comprehensive referral system. That's the overarching big goal that we wanted to make sure that we have in place with this pilot project. And in August, Freighter Hospital implemented the changes for the intake questionnaire when folks come into the hospital, and 600 people had gone through the patient survey. And of 100 of the 600 had identified food insecurity. And we were able to obviously get emergency bag boxes of food to those individuals, to those families, but also touch some of those other issues that they were experiencing at the time. Maybe it was housing or transportation. And you don't have to be an expert of all things. Feeding America Eastern Wisconsin is not a workforce development organization, but we're able to connect people with job opportunities, with housing resources and things like that. And so we know, from this, in this short period of time, because this is in the first year of this project, we know that it's working. And being able to expand and build our network to make sure we have a more impact in the communities that we're serving. And the last goal was to collect data that we can use to provide more equitable and just services. And so we are collecting data rapidly on this because we want to expound on it. We've set 3-year goals, we set 5-year goals, and we want to have great and clean data that helps us, guides us in that direction. And so these short-term goals in the first year was laid out, and it's been hitting on the mark since the launch earlier this year. Next slide. So I just wanted to remind folks with something that was said in the planning of this webinar, this training, was, to remember to be empowered, be creative, and opportunities are endless and unique. And as that was said by the colleague on this call today, I thought, wow, that is really what this work is all about. It was a great reminder. And I hope all of you all have been empowered and inspired today to continue doing the work that you're doing and even more impactful. Thank you.
Thank you so much, Martha. Collaborating generously, what a phrase. And I think that coalition work that you spoke to is such a great way to build in sustainability and some of that sustainability that Justin was speaking to earlier too. So thank you so much, Martha. And now we'll pass it to our next poll question before we get into our activity. So Mike's going to put up that poll question right now. Our question now is, do you have a clear understanding of how to build and expand a network? So far, folks are saying yes, which is great, but we want to give you, there's still some opportunity through this activity and additional conversation to continue to grow and build your confidence in doing this, hopefully by being inspired by listening to these experts and folks that are clearly really passionate about this work too. So if you're saying not yet, that's okay. There's lots of time, and we learn by doing this work. So don't be discouraged. It looks like did Mike share those results? Awesome. Okay, awesome. So then we've got almost 92% saying yes already, which is great and exciting. Everybody's feeling ready to go for open enrollment, which is very cool. So Justin, I'll pass it back to you for the activity.
Sounds great. Thank you, Courtney. And thank you both, Trish and Martha. Awesome presentations. I feel inspired after hearing both of you speak to the work that you've done and sharing your stories. So I think we can take, all these bits and pieces, the stories, the application, and think about how, we can all start to do this work if we haven't already, or start to apply some of this strategy to the work locally. And I think that's, for me, I think it's fun to do this activity. So I'm going to start by just providing some steps in this activity. And if you back to that, a request for pencil and paper or pen or some writing implement, as my dad would say, to do this yourself. If you're very fancy later on, you could try and do this some software, but just to draw, we're going to draw for a little bit. And we're not going to draw the personal level network yet, but we're just going to talk through what those steps look like. So on this slide, you'll see, and I think that Martha referenced this a few times, this kind of hub and spoke concept. And often in personal networks, when we draw them, it's best to understand them with hub and spoke. And what I mean by hub and spoke is at the middle, that would be the hub, or you. And if you're drawing a personal network, this could be all your friends or your family or your coworkers or colleagues, right? You would draw all these other people, individuals on the periphery as individual circles. You can put their names in them. And then you would draw lines, right? And the lines would be representing the relationships. And again, we're not doing this quite yet. This is just to talk through some of the practice. So this would look like a solid line from one to another. You have a strong relationship or a relationship with that person. A dashed line would be a weak relationship. And again, weak ties can be useful, especially in our professional work. I'm not going to advocate for weak relationships in your personal life, but that's up to you. And then you could also think about what the lines between those nodes, if you will, or those other people look like. For example, if you don't see a connection between those folks, that they don't know each other, but you know both of them, we could do what's called closing the triangle. And you could facilitate that connection. And this would also more strengthen your work. And I'm going back, I'm putting the lens again on our enrollment or outreach work at an organizational level. That can strengthen your work across the whole community by connecting others and closing those triangles. So that's the individual application. Next slide is we're going to actually do this at an organizational level, but the same concepts apply. So now we get a draw. And what I'm going to ask you to do is, I think, we have time for let's take about 3 minutes or so, 3 to 4 minutes. And we're going to start these maps. And these are they are a fluid living kind of document, meaning you can start the map here. You can draw some more of it on your own time. You can think about and add to it over time. You can draw in more connections as they're made. So it's not a fixed product. But let's start off by putting your organization or your work in the middle. And I'm going to talk all this through organizationally. If this is harder for you to grasp, or you just don't have those organizational level connections or even awareness of who those organizations are in your community yet, you can do this at the individual level if that makes more sense to you. However, I challenge you to kind of do the research and figure out where those organizations are, who they are. So put down yourself, your organization in the middle, put down at least 5 other organizations if you can around the periphery. And then draw lines, a solid line, and these steps are on the slide, obviously. Draw a solid line if you are connected with that organization. Draw a dotted line if you maybe have a weak connection. Or if you can think of organizations that you should be working with after hearing from myself, Martha, and Trish. Write those organizations down, but if you don't have relationships, just don't draw any lines yet. So we'll take, like I said, 3 or 4 minutes to do that. And we were going to play music at this point in time, and I promised Courtney I wouldn't sing. So we'll have to bask in drawing silence, I suppose.
If you want to beatbox, Justin, feel free to begin now.
Don't put me on the spot now. Okay. And Courtney, if you want to go back to slide 38.
Sure.
Wrap up with the last 90 seconds here.
Thanks. And we do have just a few comments. We have, surprised at how many connections you already have that could be beneficial, which is great. And then needing some more connections, and that's fine too. Where outreach is a never ending process, right? I think we could all agree that there's never an end to this work of building connections and finding new partners. So there's always more to be done.
So just wrapping up with the activity, and again, I know some of you may get into this if you like drawing or like just thinking in this kind of way, and definitely take this outside of this space and continue to work on it, or even consult with other people at your organization that may know more of these nodes to draw, if you will. And just remember that going back to those kind of rules about network building is, you don't need to draw lines between every single one of them to connect all of them. That's too much work. You may not have the relationship budget to do that. You don't need to have solid lines with every one of them. It could be a dotted line or a weaker tie situation. And also, this gets a little more nuanced, but you in the middle, you don't have to be the hub. That burden doesn't have to be on you as the organization. It just helps us to draw, to understand. But eventually networks can develop to become self-governing, meaning everyone kind of plays that role in connecting other people, and it's not the hub, but that's how we can understand it. So just some little nuggets to kind of tease you into some more network mindset thinking. Next slide. I want to point out one other resource, and this is from my prior role at County Health Rankings again. This is called their Partner Center, and it's on the County Health Rankings .org website, but it provides a really good way to think about these sectors too, that I know were brought up in both of the other conversations. And it gives some insight on what they look like, who those organizations could be in your local community if you were stumped in thinking about that, and also how best to start conversations with them or connect with them. Next slide. And I don't think we have time to run through this full activity, but I think it's always helpful when you have a longer session and a lot of good content, and not speaking for myself, good content, but when there's a lot of rich information in the last 75 minutes to kind of capture some nuggets here. And I think that this 3-2-1 helps. So maybe quickly, as Allison takes the mic here, just jot down 3 ideas or concepts you want to remember from the past hour and 15 minutes, maybe 2 questions you still have that are lingering, and 1 action point or 1 insight you want to move forward with. With that, thanks much, and I'll pass it along to Allison.
Thank you so much. Those were such tremendous tools and techniques and ideas. I definitely took away a lot. So thank you, panelists. And, we're so pleased. I think for many of you in the audience, Courtney is probably a new face for you. She is a new member of Covering Wisconsin's team, and somebody who is also helping us to grow our partnerships and really dive into that even more deeply than we've been able to do. So pleased to have Courtney on our team. Okay, so with just the last however many seconds we have, I know it's at noon. So we need to do the gift prize drawings that we do every day. We missed the one yesterday, sorry about that. And the 2 names that I have, so the name from yesterday, the winner is Sophia Harrison. So congratulations, Sophia. And then the name for today is Linda Janicki. And I apologize if I'm pronouncing that last name incorrectly. So congratulations, both Sophia and Linda. You will be contacted by a member of our team with more information for that. All right. All right, well, thank you again, everybody. Great work and really awesome content. So we look forward to seeing you tomorrow. Tomorrow's our last day, and have a great rest of your day. Bye.